Hi everyone, it's my pleasure to open our Global Health International Congress. Welcome to the first day of our event. My name is Luisa and I'm a medical student at UniBH Brasil. I would like to thank UniBH, Anima, São Lucas Educacional, Ambos and Abrasco for supporting this project. Before we begin, I would like to ask two questions. The first, what is global health? For that question, I will just choose one of the many definitions we have today. Global health is those health issues that transcend national boundaries and governments. We will discuss it a lot in the coming days. And the second question I would like to ask is, why talk about global health? So the political, economic, and social scenarios, conflicts, climate change, migrations are factors that directly influence the health of a population. International actors constantly influence governments' health policies. However, this topic is still little discussed. For this reason, this project was born. It's an honor to present the first International Congress on Global Health, Health in an Interconnected World, a virtual gathering that aims to transform your understanding of health. We expect that through this event, you will discover interconnected world and, much like ourselves, fall in love with this area of study and with the search for solutions to global challenges. It's a pleasure to have you all with us. Welcome. So, to start our discussions, I would like to invite the mediators and support team, Dr. Carolina Borges, social epidemiologist and associate professor of public health at the College of New Jersey. She holds a PhD in data public health and master in public health focused on epidemiology. Currently visiting science at the Department of Social Behavioral Science at Harvard. I would also like to invite Kenneth Lam, medical student at Taipei Medical University, Taiwan, and Letícia Sacramento, medical student at UniBH Brasil. Now I will turn the floor over to you, Kenneth.
Hi everyone, I'm Kenneth, and thanks for Louisa for introducing me. So, uh, to start off with, today we're so honored to have 3 different speakers talking about global health with us. And let's welcome for our first speaker. Our first speaker is Dr. Juliana Souza. Graduation, master, and doctorate degrees by the Faculty of Medicine at UFMG, with a fellowship doctorate by the University of Utah. She is a specialist in family and community medicine by the Brazilian Society of Family and Community Medicine, postdoc visiting scholar at the Neuroscape Lab at the University of California, San Francisco, member of the multidisciplinary research group in neurofibromatosis. She'll be bringing with us the topic COVID-19 and global health. Unite we stand, divide that we fall. Without further ado, let's welcome Dr. Juliana Souza.
Hi, everyone. Can you listen? All right.
Yes.
Thank you. Greetings, everyone. Hello, all. I hope you all are well, taking care of yourselves, of your families, your communities in this very difficult moment to all of us. My name, as Kenneth introduced, is Juliana Souza. I am a family and community medical doctor and also a professor at UniBH. I'd like to start by thanking the organizers for inviting me, and with a special thanks to Luisa Gontijo, my former student, who invited me and gave me the opportunity to be today, this great opportunity to be with you today, discussing with students, professors, researchers, such an interesting theme, which is global health. So my proposition for the next 20 minutes or so is to take a broad look at the impact of COVID-19 on global health using it as an opportunity to consider other big challenges to global health and health systems, having globalization and deglobalization as our background. So I'll try to share my screen with you. Are you with me now?
Yes.
Beautiful. And we will quickly go through challenges such as climate change, migration, food security, that you all will approach over this meeting. I'm having an issue trying to, okay. In order to start, I believe that two concepts that oppose themselves should be quickly revised. The first one is the definition of globalization or globalism, which is the word used to describe the growing interdependence of the world's economies, cultures, and populations, brought about by cross-border trade in goods and services, technology, and flows of investment, people, and information. The second one is the term deglobalization or nationalism or decentralization, which is the process of diminishing interdependence and integration between certain units around the world, typically nation states. It is widely used to describe the periods of history when economic trades and investments between countries decline. So those are terms that I believe we should be discussing right now. So previously, at the beginning, globalization was the name of the game. The trend toward greater political and economic integration was initiated after Global War II, and we have been surfing this wave for a while now. The fruits of cooperation were plain to see, and globalization appeared to be a win-win game. Nevertheless, for the past decade, the world has been undergoing a period of what we might term deglobalization or decentralization or nationalism. The past decade has been a time of growing nationalist governments in the Americas, in Europe, in Asia, in Africa, as a clear expression of an increasingly polarized and fragmented world. Sorry. Sorry. So it seems and it feels that as if over the decades, we have globalized disease and social determinants of health inequalities, while deglobalizing the shape and capacity of health systems to deal with this reality. So with globalization, we all know that health risks became international problems. The links between globalization and health are complex, and globalization can affect health in many ways, either directly at the level of whole populations, individuals, and healthcare delivery systems, or indirectly through the economy and other factors such as education, sanitation, and water and food supply. So here are some of the issues we have been globalizing. So racial and social injustice are globalized. And we all know that as inequality, we all understand now, I think, that inequality protected segments of society endangers the society as a whole. That is true whether the threat arises from disease, racism, or extreme poverty. We also globalized the weather. We also globalized climate change through air pollution and increasing allergens, through extreme heat, severe weather, environmental degradation, water quality impacts, water and food supply impacts, changes in vector ecology, degraded living conditions and social inequalities. All this is expected to increase deaths and injuries, especially in low and medium income countries. I'm having a problem to forward my slides. Sorry about this delay. Same thing we can put in perspective for migration crisis, as it shows by the mass migration from war-torn regions to safe havens countries. It was globalization that effectively connected those troubled regions to the world's safe havens in the first place. And it's important to highlight that deglobalization through border closure, border fences, and border patrols can only partially mitigate that mass migration movement. And finally, once I chose COVID as the background of this small speech, epidemic and pandemic. So the pandemic sweeping across our planet is a grim reminder that we humans are a collective, that with all our differences, we are connected to one another, that life is a global enterprise. One individual's health can impact not just on his neighbor's health, but on the health of someone half a world away. That's why I chose to focus on the global impact of COVID-19 pandemic over global health and its relationship with globalization and deglobalization process as a way to encourage reflection on these topics. So this is a history that we all know. The World Health Organization declared the novel coronavirus disease 2019 an emergency and international concern on the 30th of January 2020, and a pandemic on the 11th of March. And from that moment on, we all have our histories to tell. Personal histories, community histories, country histories, and according to COVID-19 dashboard by the Center for Systems Science and Engineering at Johns Hopkins University, my last update was on the 19th of November. The world reached 56,655,118 global cases of COVID-19, with 1,356,049 global deaths. So numbers are huge, and we all know that things are getting worse instead of better in several places right now, despite of the presumed proximity of a vaccine or vaccines, which are really welcome, by the way. So despite decades of work by many multilateral organizations and national governments, the COVID-19 pandemic reveals the weakness of our global public health systems. Colonial and racial legacy of global health has solidified global power differentials that put some populations systematically at risk and severely limit our ability to work together for the health of all. And COVID-19 brought to light this very well-known condition. So we now know that ethnic minorities make up to 14% of all key workers who cannot work from home and protect themselves from COVID-19. That ethnic minorities are more likely to live in urban areas where transmission rates of COVID-19 are higher. That they are also likely to have less living space. And some of 34% of all critically ill COVID-19 patients were from an ethnic minority. So we are living in a historic moment, a crisis brought on partially by COVID-19 pandemic and partially by defunding of basic public health systems in the context of long-standing global power differentials. And these differentials shape the ways we think about and respond to disease, risk, health, well-being, and survival on a number of important levels. Health systems already facing enormous challenges, underfunded and understaffed, are the norm rather than exception at this time of COVID-19 pandemic. And also, besides of all this differential, we can understand what should be done, what public health attitudes should be towards COVID-19 pandemic, and we cannot see this happening in such a dichotomic reality over the globe. So many people blame the coronavirus epidemic on globalization and say that the only way to prevent more similar outbreaks is to deglobalize the world. Build walls, restrict travel, reduce trade. COVID-19 as the pandemic of the moment has been used as an excuse to defend nationalism, isolation, and fragmentation. And that is what we have been witnessing from the beginning of COVID-19 pandemic. Nationalistic disputes for personal protective equipment. We've all witnessed this. And it is all over the news for us to see that even inside the same country, there has been disputes for protective gear. And this week, the same sort of competition, globalism against nationalism, has started over vaccine patent. And this is something I pulled out from an Indian newspaper today in the morning for us here in Brazil, which shows that this is already in process. Rich nations may use patents to cut off easy access to COVID-19 vaccines in developing countries. So we already have World Health Organization discussing with World Trade Organization, and the main issue is the vaccine. And it is not even authorized anywhere in the globe for a while. So some people think that the right path is just the opposite, that the real antidote to epidemic is not segregation, but rather cooperation. First, it implies that you cannot protect yourself by permanently closing your borders. However, while short-term quarantine is essential to stop epidemics, long-term isolationism will lead to economic collapse without offering any real protection against infections. So why you cannot protect yourself by permanently closing your borders? Second, real protection comes from the sharing of reliable scientific information and from global solidarity. When one country is struck by an epidemic, it should be willing to honestly share information about the outbreak without fear of an economic catastrophe. Third, international cooperation is needed also for effective quarantine measures. Quarantine and lockdown are essential for stopping the spread of epidemics, but when countries distrust one another and each country feels that it is on its own, governments hesitate to take such drastic measures. And fourth, perhaps the most important thing people should realize about such epidemics is that the spread of the epidemic in any country endangers the entire human species. So, to make my long story short, I will finish with the words of Yuval Harari, the brilliant Israeli historian, bestseller book author, with whom I really agree on the defense of globalism. In this moment of crisis, quoting him, in this moment of crisis, the crucial struggle takes place within humanity itself. If this epidemic results in greater disunity and mistrust among humans, it will be the virus's greatest victory. When humans squabble, viruses double. In contrast, if the epidemic results in closer global cooperation, it will be a victory, not only against the coronavirus, but against all future pathogens. And I agree with him. I do believe that united we stand and divided we fall. Let's do it. Thank you. Thank you all for your attention. Obrigada.
Thank you very much for Dr. Juliana Souza's presentation. It has talked about how we should combat the virus and how we should deal with the effect of globalization and depopulation, and how those effects helps us to combat the virus together. And if you have any question for Dr. Juliana Souza, please save it for now, and we will have our discussion section afterward when you will be able to ask questions. Next, we will have Dr. Sherry Prasad to introduce about the topic Health System for Global Health. Dr. Sherry Prasad is the Carlson Chair of Global Health and Executive Director of the Center for Global Health and Social Responsibility at the University of Minnesota, Professor and Vice Chair of Education at the Department of Family Medicine and Community Health at the University of Minnesota, Adjunct Professor at the School of Public Health, and a Fellow at the Institute on the Environment at the University of Minnesota. He is also an honorary visiting professor at the University of Cape Town, South Africa. So, without further ado, we will please invite Dr. Sherry Prasad to share his presentation with us.
Thank you, Kenneth. I really appreciate this. And thank you for the organizers. This has been wonderful to be part of a really august group of presenters. And Professor Souza, I think your presentation was perfect. And I hope my presentation catches up on some of the factors that you talked about. So I'm going to start with sharing my screen first. So just bear with me. Professor Souza did a really good overview of some of the tension that's occurring right now, particularly around the conversations about globalization and deglobalization. What I'm hoping to do is to do a little different approach towards it, particularly looking at health systems. One of the things that I'm particularly thrilled is that I'm a family doc, and Professor Souza also is a family doc, so I feel a little bit of a kinship with them. I feel that we all have to bring our own colors in melding this beautiful picture we talk about in terms of health systems. Has that happened before? Probably not. And that's my argument today. A quick introduction. Thank you, Kenneth, for a really wonderful introduction. That was pretty kind. And my email is there. If anyone wants to get in touch with me, please do so. I come from this place. This is from last year. We can't do this now because we are all under a mask mandate or indoors these days. So I come from a very cold climate right now. I also come from a place that is beautiful, but also has got some ugliness. My office is about 2 miles from where George Floyd was murdered. And I feel that the George Floyd murder has set apart a particular narrative in global health, which is asking the question about racism, neocolonialism, and the importance of resetting the whole expectations of global health. So with that, I always say that every presentation needs to have one complicated image. This is my complicated image, right? And the reason I'm putting this up here is for 2 things. When we talk about health systems, we talk about it being an interesting interaction between many subsystems. And over the past many decades, our health systems have gotten more complicated. Is it necessary for us to be that complicated? Well, that's an interesting question, isn't it? When the COVID virus hit Italy in the late spring, and when there was a lot of deaths there was an essay that came out of there which was quite telling. It asked the question, over the past many decades, Western health systems have designed health systems to be person-centric. And we have done a decent job, not a great job, a decent job for that. If you have money, if you have the right access, if you have the right, in the US, insurance, you can get good personalized care. But what COVID has brought up the question is that we need to have a more community-focused approach. And that is what is missing in a conversation about health systems. So we look at health systems generally in this paradigm. And again, please don't spend too much time with this. I don't like complicated diagrams, right? There is a reason why we should say that this is important for us in some ways, but this is also some of the problems that we have, because this interconnecting maze that we have built in taking care of an individual patient has unfortunately not helped us attack the very premise of what COVID is posing. In many ways, COVID is a stress test. And as a world, we have failed rather badly. So with that, whenever the question comes about global health, I go back to a little bit of an historical perspective. And if I can, in a very broad way, divide global health, I would divide it into a few eras. Global Health 1.0 was probably in the middle part of the 19th century to late part of the 19th century, where going to an exotic place, discovering a new disease, sometimes naming it after yourself, was more like a Wild West. It was an adventure. Many important discoveries were made at that time. And don't get me wrong, they were important. This is a photo of Lieutenant General Leishman, after whom leishmaniasis was named. My question is, should it have been named leishmaniasis? Or why shouldn't we have called it Kala-Azariasis? As in Kala-Azar, the bad disease found in North India. Or some other form, why is it named after an outside person? Again, please understand, I'm saying that this was a time of adventure, but it was also a very colonial approach. There is literature from that time that talks from the French colonial army in West Africa saying that a physician is better than a battalion of soldiers in winning over populations. So global health comes from that murky past. Now, moving on to Global Health 2.0, a good part of the 20th century was around a premise that, well, those poor people have nothing. This was the growth of hospitals, mission hospitals in many ways. And again, some wonderful work being done there. This is a photo of the Christian Medical College in southern India, in Vellore in southern India, that did some amazing work and continues to do some amazing work. The question that has followed is, in the growth of that was based on a deficit-focused development, as in, oh, those poor people have nothing. did that lead to the subjugation or the non-development of indigenous health systems? And that's a huge question we still don't have a clear answer to. Now, let's move on to the latter part. Professor Souza mentioned after World War II, the growth of global health. And one of the important tenets of global health in that was single disease approaches. Malaria or bust, HIV or bust, TB or bust, or Ebola. Don't get me wrong, they've done some amazing thing. Malaria eradication program was sort of a failure, but the malaria control program has been really effective in decreasing the malaria burden. It's not solved the problem on malaria, but it has brought down the system of malaria. HIV, PEPFAR, has been really remarkable in decreasing the number of HIV patients in sub-Saharan Africa. The question that has followed is, has there been spillover effect? Has the amount of money that has been invested in this individual disease-focused approach, has it solved the problem of community-based problems? What communities really need? That, I think, an essential challenge of this Global Health 2.0, where these vertical programs are amazing, but there is no spillover effect. For example, there were more than $4 billion spent in Liberia during the last epidemic of Ebola there. Has there been a spillover effect? You can make a case that not enough. We should have done more. So then, if that is the case, what is Global Health 3.0? Before I go to that, I would like to come back to a definition of global health that has been dear to my heart. And again, Professor Souza mentioned global health in many ways, but this is a definition that has been dear to my heart, partly because it talks about two important things. One is improving health, which is a very broad concept. And the second is achieving health equity for all. And I think these two are cardinal principles that we need to hold dear to us. This doesn't talk about sickness care. Now, I understand sickness care is an important part of health. This is about health in a broader construct. And that is very important for us to keep in mind. So COVID, we talk about COVID, we talk about all the devastating effects of COVID. But you have to keep in mind that when our attention shifted to COVID, our health systems were not designed to take care of health in its broad construct. Because of COVID, we're going to have 1.4 million additional TB deaths by 2025. India is sitting on a powder keg of multi-drug resistance TB. There's more than 29 million multi-drug resistance TB in India. We are not sure what's going to happen in new numbers. 2.3 million child deaths and 113,000 maternal deaths over the next 12 months. That is inexcusable. And this is what I'm really concerned about, the deepest global recession since World War II. Because we know health is a construct that is dependent on multiple factors, and economic development is a key part of health. Many countries, some numbers that I'm hearing are 20 to 25% shrinkage. We're going to have malnutrition. We're going to have so many problems that as a system, we have not attacked properly. So if that is the case, Global Health 3.0 should be based on these tenets. Number one, social determinants of health matter. We emphasize the importance of clinical medicine, but clinical medicine probably contributes to about 10% of the overall health of a community. At best, 10%. But our emphasis has been on clinical medicine. What about the rest? And when we talk about social determinants of health, it's not a passive construct, it's an active construct if you consider the political determinants. Because finally, social determinants are determined by the policy that people make, and policy is determined by politics. Professor Souza very beautifully talked about the nationalistic fervor that's going around the world. That is politics. That has got a direct link to the health of communities. The next part, let communities lead. Let the agenda be set by communities, not by a donor. The term donor itself creates a power imbalance, right? It shouldn't be that there are a large NGO or a private philanthropy is dictating what next project should be done in a community. Let local capacity be built and let the communities lead. And the third part that's very dear to me, and I'm sure Dr. Souza will also agree, healthy communities need generalists. We need generalist practitioners in community. And by that, I mean public health and primary care. And the last part, in this interconnected world, we need to share the know-how. It's not about holding our secrets to ourselves. So with that, I want to bring up one final issue. My talks are never done unless I give a little emphasis on primary care. I'd like to emphasize the importance of a definition that Barbara Starfield, who died a few years ago, talked about the importance of primary care in any healthcare system, because she feels, and I feel strongly, that a system that is based on public health and primary care is the answer. It forms the horizontal basis on which vertical programs can then be placed. The challenge that we've had is that we've placed vertical programs, assuming that the vertical programs will solve problems. Sometimes it has, smallpox, for example. But majority of times it has not, because it has not let communities be resilient enough to answer the next question that comes. And guess what? COVID is not the last one we are having. We're going to have more questions that is posed our way. So what do we mean by primary care? This is the 4 cardinal principles. First, contact with the patient, continuity in patient care, comprehensive approach in patient care, and coordination of patient care across the entire health system spectrum. I'd like to add one more C that is dear to me: community. So the future of global health is about learning from and with each other. Most of you here are students. In some way, I would say my generation has failed. It's up to you guys now, right? I want you all to understand that there is this comprehensive principle that we are all in this together, that the world is interconnected. For a minute, let's assume the whole world is an organism. The whole world is an organism, and we are all interconnected. So we cannot, in our own way, talk about taking care of one part of the organism. We have to take care of the whole world. And if you think COVID is a problem, watch out when we see more effects of climate change come our way. Thank you.
Thank you very much,
Kenneth,
with the presentation that Dr. Shri Prasad has given us.
Kenneth, I think a few minutes for question and answers if you want me to stay around for now.
Maybe we'll do it in the discussion. I'm not seeing any questions yet, but then maybe we can leave more time for the discussion period, so that maybe our participants can direct the questions to you at a later time. So thank you, Dr. Shri Prasad has talked about the 5C concepts, and then remind us that our health system shouldn't be only tackling about COVID-19, the immediate effect of the COVID-19, but also about different effects that brings about the COVID-19. And also reminding us that our globe should be interconnected, and we should tackle global health problems together as a whole, but not in different parts of the world. Next, we're going to have Dr. Louisa Savas to introduce SUS, the construction of a universal public and free system. Dr. Louis Savas is a medical doctor graduated by the Pontifical Catholic University of Minas Gerais in Brazil, first-year resident in family and community medicine at the Federal University of UFSJ. Posted at a primary care health unit for the Unified Health System. Throughout her graduation, got involved in extension projects at preventive medicine and public health, also dedicates to write literally medical tales and promote health education related to SUS on social media. So may we invite Dr. Louisa Savas?
Hello, thank you, Kenneth. Let me present my presentation. Okay, I must say it would be very hard to follow such brilliant speakers. So I'm Luisa. I recently graduated from med school, and now I'm a first-year resident in family and community medicine. I work in a basic health unit of the Sistema Único de Saúde, the Unified Health System, which we call SUS. Also, I promote education about it on social media to raise awareness, and I'm very glad to the opportunity to be here. I must say, my English is a little rusty, but if there's any questions or if I need to clarify something, just let me know. My email address will be on the end of this presentation. Today, I will talk about SUS, the construction of a universal, public, and free system. I want to clarify that I have no conflict of interest. I talk about SUS because I love it and I believe in it. So it's first important to understand each word that forms SUS. Unified means no other public system. SUS serves 100% of the population, approximately 75% exclusively. In other words, we have a rate of approximately 25% of people with health plans. But even so, some services are exclusive to SUS. Health, integrated vision in health, not disease-based. We have an expanded concept of health, which is not limited to exams, but also access and well-being. And system, diverse areas involving health. As there is an integrated vision of health, there is an entire system to supply the needs. SUS is formed by all health actions and services provided by federal, regional, and municipal institutions, of the direct and indirect administration, and of the functions maintained by the public power. It can be considered one of the greatest social achievements, which came to be in the 1988 Constitution with a sanitary social movement. Its principles are in line with democratization in health actions and services, which are no longer restricted and became universal and decentralized. SUS is the way to provide health as a right, as a human right. There is a notion centered on preventive medicine and health education. The basic rights are also considered health and a government responsibility, such as food, work, salary, education, the environment, basic sanitation, housing, entertainment, health and pharmacological surveillance. This means that well-being became a health indicator. Health is a universal right and guaranteed by the federal constitution for free to everyone. We have doctrinal principles and organization principles. As a doctrinal principles, we first have universality, which means health for all Brazilians in the national territory without discrimination. And it can also serve foreigners who are here. The second principle is equity, which is to provide the necessary services according to the needs of each location. Our territory is huge, and so are our social discrepancies. So we need to treat equals as equals, but different as different. And the principle of integrality seeks to guarantee the individual healthcare that transcends the curative practice, contemplating the individual at all levels of care and considering the subject inserted in a social, familial, and cultural context, always considering the social determinants Dr. Prasad mentioned. As organization principles, we have first the decentralization, which transfers the management responsibilities to the city administration, who understand closely the needs of his population. With regionalization and hierarchy, service must be organized at levels of increasing technology complexity, arranged in a defined geographical area and with the definition of the population to be served. Social participation is the citizens' right to participate in the construction of SUS, with the inclusion of citizens in formulation of public policies in defense of their rights to health. Is a health model guided by primary care. which is the base of the system. We have the family health strategy on the basic health units, which are distributed across the country in teams to serve a population determined by the territory in which they live. Involves other initiatives, street medical consultations, which serve people who live on the street, the Best at Home program for home care, the Brazil Smile program for oral health, the Community Health Agents program. These agents go to home visits, and they are the connections between the community and health services. It can vary, but in general, in a team, we find one doctor, one nurse technician, at least one community health worker, one dentist, and an odontology technician. We can also have a family health support team. It's a multidisciplinary team, psychologists, physical therapists, social worker, nutritionist, speech therapist, physical educator, veterinarian, and a lot of others. There are also a few doctors' specialization like gynecology, psychiatrist, pediatrics. But SUS is not just about primary care, exams, and hospitals. It's an integrated vision of health, right? We also have other services. Popular Pharmacy gives us numerous types of common medicine we need. Anvisa, the National Health Surveillance Agency. Vaccination with the National Immunization Program. Treatments to tuberculosis, HIV, leprosy. SAMU, the Emergency Mobile Care Service, which briefly I can say is the structure of ambulances. Health surveillance. National Water Quality Monitoring Program for human consumption. Blood donation, human milk banks, chemotherapy, organ transplant, science and technology, health surveillance of zoonosis, social assistance. But Luisa, how do we pay for it? Well, I'm not qualified to talk about economic terms, but I can briefly explain according to what I know. First, it's important to understand that Brazil is the only country with more than 200 million inhabitants that has a free public health system. The federal constitution provides that these spheres of government, the three spheres of government, federal, regional, and municipal, finance the SUS, generating the necessary revenue to defray the expenses with public health actions and services. So clients multiply annually, so cities multiply annually at least 15% of the collection of taxes on actions and public health services, and states about 12%. In the case of the federal government, the amount applied must correspond to the amount committed in the previous financial year, plus the percentage related to the growth of economy. SUS is not perfect, so we have inadequate and unstable funded, less participation in social control, insufficient public policy integration, devaluation of workers, inefficient management and extensive lines, low autonomy in the production of strategic inputs and medication. And the main one, stigma. Unfortunately, people still think it's only for the part of population with low income, and it gets in the way of defending the system. We have a huge country with a lot of social problems. It's a system in construction and will probably always be. As a conclusion, the existence of SUS is the base for defending a model for a society that values social equality and understands health as a right, not product to be bought. To finish, I would like to read a tale I wrote. I am also a writer. I mostly write about my experience in medicine. So there is this gentleman I saw for the first time on a Tuesday afternoon. He was with his wife and had a calming speech. He started the appointment explaining he didn't return at the last time he came and had a few exams at the beginning of the year because the pandemic arrived and he avoided leaving his house. I asked him about his blood pressure and the use of his medication, but he soon made it clear he does everything as requested. But whenever he enters a healthcare center, his blood pressure increases right away. We call it lab coat hypertension, I explained. I don't even wear a lab coat, but you must have been very happy to come here. You got emotion and the pressure went up, huh? I said, smiling. And what was meant to be a joke was the truth. It's just that I'm not used to it, you know? I still haven't gotten used to seeing a doctor. And what he told me is the reality for many. He worked as a child in the sugarcane fields. He gained his money literally by the pound of his family. His family needed money, so he didn't even have breaks for lunch. When it rained, he worked double because the pace got slower. With a lot of effort from his parents, he managed to get into a school, and when he finished the 4th grade, he received a certificate. He said that people from all around would go to see his certificate and would ask him to write letters. At that time, almost everyone earned less than a minimum wage, and no one had a doctor to go to, he told me. I kept thinking about this case. I kept wondering what I could say about him, but stories explains itself. It is for this gentleman, now literally after working as a child in the sugarcane fields without access to health care and other basic rights that today are hard to maintain, that I defend SUS. Thank you.
Thank you, Dr. Luisa Safas, with her amazing presentation talking about the universal health coverage, the SUS in Brazil. And then I also think that the universal health coverage is a really important, take a really important role in the global health, and how we can improve them and have access to let people to have access to health care is really important to construct and establish our global health. So I think we'll be having our discussion section now. So Dr. Carol and I will be asking questions to the presentation, like to the speakers. So we have received one question from the floor. So the first one is that let me see. Like he said, hey, I have a question regarding COVID-19. As per latest statement of WHO, they said that vaccine is not enough to end this pandemic. So how can we control this pandemic? I think this question applies to all the speakers. So do anyone would like to speak first?
So Kenneth, Shali here. I'm sorry, I'm on a different gadget here. The question is a beautiful one. Yes, a vaccine is not a final answer. It's one of multitudes of strategies in controlling COVID. I still think it significantly depends on basic public health. We need to treat each other with respect, wear masks, do social isolation, till the current epidemic peaks start curving downwards. The vaccine is an added strategy in combination of everything else. Over.
Yeah, excuse me, I totally agree with Dr. Prasad. I do believe that the vaccine is a very welcome tool, but it's only another tool. And maybe it's not even the most important one. We have to think about it as something that we will add to what we already know is effective to try to control COVID-19. And as I tried to bring on my presentation, and Dr. Prasad also just said, is that I believe that we can take care of each other, of our close ones, families, friends, our communities, and as a global community, take care of each other, and that this will be our most important instrument, tool to survive this pandemic. as a group, a global group, I mean.
Dr. Luisa Sefas, do you have any response to the question as well?
No, I think they responded well.
Maybe Dr. Carolina can conduct the next question.
Sure. First, I would like to greet my colleagues here, Dr. Juliana Souza, Dr. Luisa Chavez, Dr. Shailene Prasad, and Dr. Omar Sherkawi to be here, and also greeting all the students for this marvelous movement, receiving an invitation of an event to discuss global health coming from students. It's something that we expect not only as a healthcare providers, but as an educator. So I am more than happy to see this happening today in the next weekend. So the question here that I received is that thinking of a call for action after the second, this is the first weekend of the event, and we're gonna have the second one. In terms of a call for action, what should be in the first step that we could address in an interdisciplinary way, how this new generation of not only physicians, but nurses and so many other important health cares that we could do better together. Dr. Souza mentioned that we are better together, and here all the other presenters. So that's the question. What should be in terms of a concrete call for action, a written one? So because the goal is after the event, we have something concrete in our hands to say, all right, this is what we received and what we got and what's gonna be next in terms of organization and thinking and targeting this new generation of our future professionals that they are advocating for global health.
Dr. Carolina, were you addressing that to one particular person, or can we just jump in?
Yeah, you can just jump into all of you. Yeah, it's a collective effort.
So, like I mentioned, I think there is probably a generational shift occurring right now. And I mentioned this in my talk that my generation has failed this tackling this problem. I have a colleague here in my university who keeps saying that if we want anything meaningful to occur at the university level, you send a student. They can do it. I would like, so the call for action from my side would be to give the students the charge of doing a few important things. Number one, we talk a lot about interprofessional education and interprofessional practice, but we don't do enough in that. We, particularly when we get more differentiated into our own health professions, like medicine or public health or nursing or pharmacy or dentistry, we don't interact enough with our other colleagues. And I think that the next generation should be learning with each other, not learning in our own silos. So that's a huge action step. And I think the students need to sort of force some of our universities to start doing more of that. And then the second point beyond that is, we talked about this, how global health needs a new approach, a departure from the old colonialistic approach. We need to respect the viewpoints of people from across the globe and have a much more democratized process in sharing information, respecting each other, and learning from and with each other. I'm tired of projects that are started in the US and then now have to be replicated somewhere else because the money is there. That's wrong. That actually doesn't solve problems. It causes more power differentials. So that second one, this audience has a fantastic opportunity to be the force behind that second one. So those are the two important things that come to my mind.
I completely agree, completely, because we've been promoting in being, okay, let's be interdisciplinary, but then are we really creating these opportunities? And now it's open for my other colleagues to provide some inputs where we should start as a call for action.
I believe, Carolina, that we should add to those points, well-defended points that Dr. Prasad brought, how can I say that? We have to reinforce, I believe, as educators, the importance of social determinants of health. And in doing so, I believe that we will be capable of contributing with more integrative professionals, not only medical professionals, but all the other health professions. And this would give us a link to this responsibility that should be a responsibility of the whole communities and the countries and from health system users on what is important, what they need, and how it should be done, that Dr. Prasad mentioned.
I can say as a student from residency, we have to understand that basic rights are not products that people with money buy. We have to have a greater vision of solidarity, of integral health, train professionals for that. We need a quality adjusted, the guarantee of of life, of well-being. Health isn't a commodity, and this is important. Everyone has the right, and someone has to have this responsibility. And I think the pandemic taught us that. Is a lesson we learned from this year, particularly.
Any other input? Dr. Omar, you also invited. You are our next speaker, but as in terms of what we are discussing, so you are more than welcome to contribute as well.
Yeah, thank you. I jumped a little bit late on to the conversation, so I missed part of it. But part of what I wanted to contribute with is related to what I'm going to talk about next, which is the role of medical education also in that. And I very much agree with all the input that were given so far. And I absolutely agree also with Dr. Souza regarding the importance of social determinants of health in that. From my experience, I've got to know so far that actually medical schools, a lot of medical schools, and I would say even most medical schools, especially in low middle income countries, do not focus on that component. Like medical professionals graduate without necessarily even understanding what social determinants of health. You approach the care to a patient only from a clinical perspective without taking into account the environment that surrounds them and all the other social determinants of health that do impact their health. And this is very unfortunate. And I do believe that there is a need for medical education system strengthening as well if we want to strengthen our health systems and therefore achieve the sustainable development goals.
here, before we go to our next speaker, we have one interesting question that came from our audience, and let me read this out. So the attendant is asking that I'd like to know if you guys, that question came from, think that countries that they have health systems, just as the universal healthcare system in Brazil, SUS, are more prepared to deal with the global issues like COVID than countries that they do not have a universal healthcare system as the US. So that's the question that came from our audience.
So we have different experience. There are countries with strong primary care and strong health systems, public and free, that maintain to deal with the pandemic better. But there are countries that even with strong primary healthcare, a strong health system and public ones, accessible ones, faced great difficulties. I can say here in Brazil, being the front line in SUS, that he has certainly a protagonist in a good result, made a huge difference. And that's the way to reach health where it would not be without SUS. This is the great importance in SUS, because gets to people where the private companies would never get. So for a country like Brazil, a huge country, a poor country, is certainly important. The other ones, it's different situations, and I don't have the information to affirm.
I would like to jump in and complete. I totally agree with you, my colleague, Dr. Luisa. It's a pleasure to be here with you today. We are both family doctors. We work on the same environment here. And I have to say that personally, I absolutely think that countries with universal access to health, they are way more, how can I say, not prepared to face COVID, but their population is in general well-served when they need some help during COVID-19 pandemic. And I have to say that although we didn't have like a very, as Dr. Prasad said, I think that we failed as a whole on all this pandemic situation. But as Dr. Luisa said, I can talk about Brazil, and I can absolutely say that it would have been even worse if we didn't have SUS. That's for sure. So I have to say that I defend universal access to health as a right, as a human right.
If I may jump in, I really like what the two previous respondents mentioned. I think universal healthcare, we'll know this more in a few years' time for actual data, right? We don't know, we can't say for sure at this stage. What we are getting to know more from the data is that, I remember the definition of global health that I put in about health equity. In countries with universal health coverage, universal health care, the health equity is so much better. Now, I would also like to emphasize that universal healthcare is one part of a larger picture of a health system. So what COVID is doing a few things, right? It's making us ask the question about how good is our access and how good is our care? And also it's asking us, are you really reaching everybody? So data coming from the US suggests that horrible. The US is really bad about universal health coverage. You folks know this by now. And the data coming from the US shows that minority populations, people with poor access, refugees, immigrants, migrant workers here in the US are really worse off with COVID. And that is a direct function of lack of universal health coverage. So it's not a final answer, but it definitely is an important part of it. Over.
Any other contribution from this round? If not, I'm turning Dr. Omar. If we don't have, I'm turning to Kenneth to introduce our next speaker of this afternoon. Kenneth, it's with you.
Thank you, Dr. Carolina. So I'm going to introduce our last speaker for the before our break. So our first speaker is Dr. Omar Shikari. Dr. Omar is a medical doctor from Morocco and the former president of the International Federation of Medical Students Association, in short, which is IFMSA. He's also recently completed a Master in Public Health at the Johns Hopkins University. He's currently the head of the AMBERS Global Health Initiative, which is a non-profit initiative aiming to empower all healthcare professionals in low and middle-income countries to provide the best possible care. Today, he bring us the topic of the role of medical education in the health system strengthening. Let's welcome Dr. Omar.
Thank you very much for the introduction and for inviting me also to join you in this discussion. Let me start first by sharing my screen. All right. Can I just get a quick confirmation that you can see my screen? Yeah, perfect. All right. So yeah, hi everyone. So my name is Omar Shikari, and today I would like to share with you my passion of medicine, in particular medical education, and its extremely important role in health system strengthening. I stumbled upon medical education about 8 years ago when I started my work with IFMSA, the International Federation of Medical Students Associations. I established back then the Professional Exchanges Program in Morocco, and this opened for me a whole new world. There is one story that I'd like to share with you because, well, it's quite relevant to our talk today, but also it shows me up until today that medical education does not take place within one school, but it requires an international collaboration too. This took place in Sudan, where a medical student from Italy went to Khartoum, Sudan, for a clinical rotation. He was placed at an OBGYN department, and he supported the staff in delivering babies. At the end of his rotation, the head of department offered him to perform a delivery on his own. But as he was just about to start, he realized that the woman had a female genital mutilation, which he has never seen before. Luckily, he was surrounded by the medical staff who took over because, as we know, or maybe you don't know, and that is fine, the procedure to deliver woman who was mutilated is different from that of other women. This is something he would have never seen in Italy, and with the nowadays increase of immigration towards Europe, he would come to see this sometime in his professional career, should he choose to do OBGYN, and he would be then more culturally sensitive to this issue. This is why these global health experiences are so important to me. They absolutely teach you to be a better doctor. And today, I would like to tell you how these kind of competencies do shape a doctor and what the role of medical education overall is in the strengthening of health systems. So first, let's understand the role of medical education or what should medical education do and achieve. And for that, I would like to introduce you to this framework, which a lot of you might already be familiar with, and it's called the CANMEDS. The CANMEDS is a framework that identifies and describes the competencies that physicians need to have to effectively meet the healthcare needs of the population they serve. These competencies are grouped under 7 roles, and a competent physician is one that integrates all of these competencies. The first one is communicator. This means that physicians should form relationships with their patients and their families to facilitate the gathering and sharing of essential information for effective healthcare. There is, for instance, active listening, how to break bad news, being empathetic, respecting the diversity of patients, and in general, just being able to facilitate discussions with patients and their families in a way that is respectful, non-judgmental, and culturally safe. The second one is collaborator. This means that physicians work effectively with other healthcare professionals to provide safe, high quality, and patient-centered care. This is an essential component of an efficient and a strong health system. And I'll get back to that later on. But in general, this means that healthcare workers need to communicate and collaborate among each other to be able to provide a safe, high quality, and patient-centered care. Not only should that collaboration take place among healthcare workers, but a high quality care also involves the families of patients, the community partners, and the other health system stakeholders. I've had, for example, a patient once who had no home, and treating him meant that I would have at some point to put him back to the street. However, we collaborated with social workers to find him a temporary placement until at least he's fully healthy again. Unfortunately, and of course, this was only a temporary solution, but this shows how collaboration can take place and how essential that collaboration is to provide care to patients, not just within the walls of your hospital, but also outside those walls. The third one is leader. This means that physicians engage with others to contribute to a vision of a high quality healthcare system and take responsibility for the delivery of excellent patient care through their activities. And you all know that very well, but working as a physician undoubtedly means that you'll be working in teams and that you will have to demonstrate leadership in your professional practice. In addition, you will have to manage human resources at some point, as well as career planning and finances. Without leaders, our work will be chaotic. This will have consequences on the quality of care of patients and therefore on the health systems too. Fourth one is health advocate. That means that physicians contribute their expertise and influence as they work with communities or patient populations to improve health. We know that patients often don't have a voice in the health systems world. This is why the roles of physicians in listening to patients and understanding their needs, then speaking on behalf of them when required, and then supporting the mobilization of resources to make a change is absolutely needed. Scholar means that physicians demonstrate a lifelong commitment to excellence in practice. That means they keep on learning themselves, but also contribute to the training and teaching of others. And lastly, or second to lastly, professional means that physicians are really committed to the health and well-being of patients and the society through ethical practice and through high personal standards of behavior. And so the last one is medical expert, where physicians pretty much integrate all of these CANMED roles, applying medical knowledge, clinical skills, and professional values in their provision of high quality care and safe patient-centered care. This is how you become a medical expert. So now, after talking about these CANMED roles, the question is, well, what do medical schools do about that? And that's the most important question. This framework was implemented in '96 and revised recently in 2015. and it has been adopted and adapted around the world, but still many med schools do not comply completely with these roles. This is why you, as healthcare professionals, should know about them and should strive to encompass these roles. Of course, medical education systems around the world are different from one country to another, or even from one school to another, but these roles should be central in the teaching of medical students. So what's the connection with health systems? Well, let's understand what health systems mean. A health system consists of all organizations, people, and actions whose primary intent is to promote, restore, and maintain health. This is not just what happens within the walls of the hospital. This is much beyond that. Health systems include, for example, a parent caring for a sick child at home. It also includes health insurance organizations or public health programs. And it includes intersexual activities, such as, for instance, encouraging the Ministry of Education to promote women education, since this is a health determinant, a determinant of health. So the WHO defines 6 building blocks of a health system. These are service delivery, health workforce, information, medical products, vaccines and technologies, financing, and leadership and governance. So I'm not going to go through all of them. If you want more information, I put the source on the slide, but let me take you through 2 of them, which I consider are very relevant to this discussion. The first one is service delivery, where good health services are those which deliver effective, safe, and quality health interventions. The second one, which is the one that actually interests me the most, is the health workforce. This includes all the professionals that work within the health system's framework and deliver health. A strong health system is one that has a well-performing health workforce to achieve the best health outcomes possible, given available resources and circumstances, of course. This means that there must be a sufficient number and mix of staff who are fairly distributed across the country, even in remote areas, and who are also competent, responsive, and productive. This is part of what makes a strong health system. Without the healthcare workforce, health systems would simply collapse. And so these building blocks contribute to the overall goal of health systems, which, among others, is to improve health. So what do you think of that? Can you think of your country's situation? And are the healthcare workforce or the healthcare professionals fairly distributed across the country? Do parts of the population of your country who live in remote areas have even access to healthcare? Most likely not, right? And that is not just the case of low and middle income countries. This is also the case of high income countries. That's how you see countries like the US and Germany trying to attract as many foreign healthcare professionals as possible to cope with the fact that they lack doctors and their own doctors don't want to go to remote areas. And as you can see, we have a long way to go before achieving strong health systems in high income countries as well as low income countries. So let's look at the situation here. The World Health Organization is actually raising the alarm about the crisis in human resources for health. 57 countries have been identified to be in critical shortages, among which 36 are located in Africa. The World Health Organization estimated that 4 million healthcare professionals are needed to bridge the gap, 1.5 million in Africa alone. This has a considerable impact on local health systems that are already fragile, as you might understand now, as the number of facilities and healthcare workforce, healthcare workers equipped to offer healthcare is reduced. It is estimated that every year, 3.5 million deaths occur in low-middle income countries from treatable diseases due to non-utilization of health services. That means there are 3.5 million people who die every year in low-middle income countries simply because they could not utilize health services. And 5 million people die because of poor quality of care. This threatens the attainment of the Sustainable Development Goals, as by 2030, 18 million extra healthcare professionals will be needed to achieve universal health coverage and health-related SDGs. If we roll this slide back, you understand that to achieve SDGs by 2030, the world needs stronger health systems. To have stronger health systems, strengthening all the 6 building blocks that we talked about are essential, and the healthcare workforce is one of them. To strengthen the healthcare workforce, the number of healthcare workers is not the only parameter that we should focus on, but the quality of these healthcare workers is even more important. Our patients need competent and highly skilled healthcare professionals who will provide them with high quality of care. And to achieve this high quality of care, medical education is of the utmost importance, and the CanMed's competencies that we talked about today play a big role in strengthening that medical education. Today, to achieve quality healthcare, medical education needs to be revolutionized. We need a competencies-based approach where the education of physicians is not just centered around their medical knowledge and skills, but is also centered around them and their competencies. We also need to build the capacity of our educators. If we expect to strengthen our medical education system, this can only be done if our educators' competencies are also strengthened. They are the ones who communicate their knowledge to the students after all. Educators should be encouraged to incorporate new methods into their teaching, such as blended learning techniques, which have a higher engagement from the students. In addition, we also need to involve students in the design of the curriculum. Medical students are not just consumers of the curriculum, but they also should be partners in the process. They should be engaged, they should be able to sit down at the table where the decisions are made, and they should be proactively asked for their opinions. And lastly, our medical education system needs digitalization. In a world where the amount of medical education, of medical information doubles every 73 days, it is nowadays even more important to provide up-to-date medical knowledge to healthcare professionals. Therefore, medical books can no longer be a sustainable solution, and students should be actually encouraged to consult trustworthy, evidence-based, and up-to-date digital medical resources. With the time that we had together today, I hope you understand that the role of medical education in strengthening health systems is really important. But most of all, I hope you understand what your role as medical students or healthcare professional is in advocating for a change in medical education and for encompassing the competencies defined in the CanMed's framework. This can only lead to better and higher quality of care for our patients. Thank you very much.
Thank you very much for Dr. Omar amazing presentations. So I actually have some questions during your presentation. So I'm from Taiwan, so I'm from the Asia Pacific region, and I think we have a very different medical system compared to the Europe or to the American regions. And then you have talked about we can like ask for changes and revolution in our medical education, but then in my point of view, like it's very hard for students to ask for resolutions. Do you have any suggestions for us? Like, yeah, it's time to change for the medical education in our school. Thank you.
Oh my God, absolutely. It's so difficult, right? And that is not your fault. It's a very complex system, right? And this should not just come from you. This should also come from the top. Like, it should be like a top-down approach as well. Like, it should come from the faculty, the university staff, and the management. It is very unfortunate, but I think, correct me if I'm wrong, I have the impression that you're involved with IFMC, since you said Asia Pacific region. But I do think that being involved in student organizations is actually really important, because this is the way you can achieve advocacy within your medical school. I do hear you. It is very important to, and very intimidating as well, to approach the dean and talk to them about that. But I do think it is a matter of doing it step by step. I do think that, for instance, just as an example, what we did in Morocco, we started with implementing our professional exchange program. And throughout that, we combined it with a research where we have shown, like from an evidence-based approach, that these experiences actually lead to increase of knowledge of medical students and make them even more competent and better doctors. And so we provided that to our university, who was then actually able to validate and incorporate those international clinical rotations into our curriculum. It was a very long road. It took us 4 years at least to be able to get there, but eventually you do get there, right? I do think the involvement of medical students in general is really important. I don't think it's your fault if you're not engaged, because unfortunately we are dealing sometimes with, excuse my language, but an older generation of university staff who don't necessarily believe in these changes. And that's why, like, we as young future healthcare professionals or young healthcare professionals, we should prove to them and show to them how important these changes are through that constant advocacy and reminding of the importance of these changes. So I can only really commend you on doing more and keep on trying to reach out to the university and trying to show them case studies from other countries or maybe other universities within the same country who have integrated these changes. And I have the feeling that these case studies can actually be the most, sometimes the most successful in making your point across.
Thank you very much. I think we also have a question from our participants. So it asks, the participants asked that, what tools do you believe are important so that the quality of remote education does not fall during online classes during the pandemic?
Do you mind actually repeating that? I'm not sure I caught all of that.
Okay. What tools do you believe are important so that the quality of remote education does not fall during online classes during the pandemic?
That's a huge question, right? There is not just a one solution there. It's a multi-systemic, multi-approach solution that has to be implemented there. I think the efforts should come from 3 entities. The first one is medical students. I do believe that medical students, and especially in these times, they have to have access to digital medical resources that are up to date, that provide them with all the information they need to be able to study and prepare for their exams, and in general, just to get all the knowledge they need. I think that's very essential first. So like digital medical resources, use as many as you can and try to look at videos, look at resources such as AMBOSS or any in general. I think these can be very impactful. The second audience, let's say, who is important in answering this question is the university staff. They also have to try to create a change in the medical education system, again, especially because of these times, to try to support their students with digitalization and with digital resources. They do know that the students right now, most of them are not even going to school or classes. They have everything online. So they have to provide them with as many tools as possible to support them along that journey. Again, digital medical resources make a lot of sense. And then that goes to the third audience, which, or the play actor is the educators. They have an essential role here. We are way past that time where we provide or where we lecture students through a PowerPoint presentation where we actually reading to students or talking at students, not talking with them. Teaching now has to be more interactive. And so there are so many techniques that could be used. One of them is blended learning, where students and teachers have to work together. Students have to read materials beforehand so that the time during the lecture or during the class is spent not just at giving you that information that you could have read online by yourself, but instead we give you that time to answer questions, answer your doubt, and then organize perhaps clinical cases or workshops to really make sure that you apply what you have learned on your own to kind of like practice, right? I believe like blended learning can be very efficient in supporting students throughout these times. I hope that answers the question.
Thank you very much. I actually agree with the ideas that our education somehow need to change. I remember that I have like watched a video talking about like our technology is changing, our environment is changing, but our education system isn't changing. Like for a lot of years, like just being input by the knowledge, and then so I actually think that we need to change for our education system. I actually have one more questions. Like you have talked about you started a professional exchange, and I'm also agree that exchanges are very important for our medical education. Like when we go to exchange, we'll learn more about the global health system or the health system around the world, etc. But then, like during the pandemic, how can we achieve that, or how can we compensate that when we are not able to?
That's a tricky question, huh? Yeah, unfortunately, I keep thinking about that. We were very privileged in being able in the previous years to travel and meet other cultures and practice in like among other cultures and so as to develop these skills. Right now, we just have to adjust to all of that, right? And I do think that in these cases, these kind of conferences that you guys are organizing are really important, because this is, I feel, the only way for us in a way to travel and having the opportunity to talk with students or healthcare professionals from other countries and experience with them and have discussions with them about their experience, about their challenges and how they approach their challenges. I do think that these conversations can definitely take place virtually through these conferences that you're organizing, through other kind of networks, right? The only thing that you're missing in that case is that practical or clinical knowledge that that you don't have in an in-person environment. And I think I don't have the solution for that. And I think that is something that surely needs to be addressed in the future if we were to get into a well, first with this pandemic, but also in case we get into other public health challenges, I think we should find a way. There are other ways, such as, you know, live surgeries, for instance, or like live like some live clinical rotations where people just offer to share like their experience live somehow. I've seen that has a lot of questions also about like informed consent and all of that. So that potentially could also represent a lot of issues, but I do think that I do see this in a way pandemic as an opportunity to actually at least start these conversations and perhaps get to a solution. I don't, and this is important. Why is it? Because it's not just important for when we go, it's not just important now that we're in the pandemic, but also when we get out of this pandemic, we have to remember that not all the students have the ability to afford traveling and afford having these experiences that actually make them a better doctor. And so being able to find solutions or being able to bring solutions to your own home, it would be also important and really innovative, and definitely more equitable for everyone.
Yes, like we also think we always think that COVID-19 is a crisis for us, but actually it brings up different opportunity as well. Like when COVID comes, and I saw like much more webinar held, and then we are able to attend webinars or sessions online. And moreover, like actually my school is also changing the way of teaching. Like they start using different digital platforms such as Zoom and more interactive way as well. So some of the COVID impact our life not negatively, but also positively. So there's always opportunities when there's crisis. And I have like another question is that often we talk about global health, like the first keyword we think about maybe the World Health Organization. So the World Health Organization, in your opinion, like what does the World Health Organization take a role in the global health system? And what's your opinion or views on the current controversial WHO?
I think I missed the last part. The current controversial of what?
Like controversial issues of the WHO.
I do believe WHO has a very important role in this. I think the best thing that WHO does is that it brings actors together. This is the only entity that brings governments from all around the world, including countries that might be a little bit more difficult to reach, such as North Korea, for instance. WHO brings all of these actors together under the same stage and talks about all of these issues that affect the health of everyone, no matter in which country you are, and to think about solutions that everyone can adapt together. I do believe that WHO brings these actors together to collaborate. And it is basically the only organization that does that. And it is the only organization that even has the mandate or the respect to do that. I do believe that's important. I fear that if there is no WHO, there wouldn't be that collaboration. And also its role important, especially in coming up with recommendations and with protocols for to improve the health in countries, and making sure that the countries are aligned in their approach. That is also something extremely important. I honestly think the world was not in a good shape before the start of WHO. And of course, I know there have been a lot of issues around perhaps the way the WHO managed perhaps this pandemic. I not also honestly sure how things could have been better in the chaos that the start of this pandemic was on. And of course, I'm sure WHO did a lot of mistakes, and many other governments also did a lot of mistakes, but I think the most important is to make sure that we actually learn from these mistakes, and to make sure that we prevent such pandemic or a similar pandemic in the future from taking place and from happening. I think that is the most important at the moment.
Thank you very much. Like I have no questions, and then I don't see any from the participants. So, do you have any last words for our students or our participants on about the global health or health system, or even in medical education?
Not really. I just wanted to say that I'm very impressed that that you all are organizing this and that the participants are following this. This is really important. I cannot stress that enough. Being a doctor does not necessarily mean that you treat a patient and then you leave them and that's it. It does not mean that you give your patient a prescription and your role does not end there. Your role does not end at the moment when you hand this prescription to the patient. Your role should be should be much bigger than that, and should go way beyond that. And to be able to do that, you have to care about social determinants for health. For instance, you should take into account the environment of the patients to provide them with the appropriate care. And to be able to do that, you have to have a great understanding of what global health is. And so I can only commend your participation and your interest in global health, because this is really important. This is what our world needs. We need better and more equipped health care professionals, and you all are on the way to do that, and that is impressive. So keep on going on, and if you have any questions, feel free to reach out to me. You can easily find me on social media. If you need to send me an email, my email address is omar@ambos.com. So feel free to shoot me an email. I'll be happy to answer any questions.
Thank you very much. I think our participants learned a lot from your presentations. So I think we're going on a break. Like our participants starts the session from 12, and then our break is till it's until let me count. It's till like 6:10 at GMT. So there's around a 20-minute break, so you can go to toilet and grab something for your snack, and then we'll be back at 18:10 GMT.
Thank you. Bye-bye.
Welcome back, everyone. Let's continue the next round of lectures. Now we will have the presentations of the work submitted by the students. The first one will be presented by Ana Luisa Silva, and the title is COVID-19 Care Cycles and the Coping Measures in the Industrial Sector. Guys, we had a little technical issues, but the presentation will be on soon.
Good night, everyone. My name is Ana Luisa Antoni. I'm from Brazil, and I'm current medicine student at UniCeub. And tonight, I will present COVID-19 care cycles and coping measures in the industrial sector. So the objective, the goals of the study was to assess the impact of the pandemic on companies in the industrial sector, but also to identify trends for the supplementary health that were aggregated or amplified by the COVID-19 pandemic. This research was sponsored and organized by Serviço Social da Indústria, SESI, in partnership with Agência Nacional da Saúde Suplementar, ANS. The method of the study was a qualitative research that was carried out between 6th of July and 5th of August of 2020. And the technique was in-depth individual interviews, but it was through flexible collection. The script was with open and adaptable questions. So the target audience was health managers from large industries that were indicated by SESI, and also owners of small and medium-sized companies. The research worked in 5 dimensions: labor, health plans, prevention and health promotion, the care cycles and coping measures to COVID-19, and also its impacts and possible trends. For this work specifically, we chose to discuss the results about the care cycles and coping measures to the COVID-19. And there were 12 large industries a medium industry, and 2 small consultancies in engineering companies. As I've already said, for this work, we will approach the results by the dimension of care cycles and coping measures to COVID-19, which presented the integrated performance of the company's health strategy and to prevent and to treat the suspected cases. The reason why we chose this topic was because the occupational health assumed a responsibility for COVID-19, even though it's a non-occupational disease. So in partnership with healthcare and assistance health, the occupational health assumed the role of monitoring suspected cases and also establishing preventive measures with flow charts and other measures. So different from the large industries, the small and the medium industry didn't have a structure that was able to provide a full day of healthcare for its beneficiaries. So with the imminence of COVID-19, the large industries were able to implement the care cycles. And here we have this flow chart with monitoring and prevent measures with home office, removal of people of risk and chronic group. And it was also important proactive leadership posture to be an example in the crisis committee, and also had online dashboards and dashboards for case monitoring, like Help COVID, communication channels to answer questions and do some guidance and follow up of consultation and examinations to identify cases, and also simplify the epidemiological survey to identify symptoms in contacted persons, and phone calling from a nurse to indicate the need to see a doctor and indicate or not the COVID-19 suspected. And here with COVID-19 suspected, we have the screening and the testing with laboratories, hospitals, private clinics, telemedicine, and the tests, PCR or serologic, and the ways to go if the testing goes positive or negative. In both ways, you only come back to work after you have no more doubts, you are free of COVID and have no more symptoms. So here is some things that were said in the interviews, and here we go. In addition to being able to call the company's clinic, we created Help COVID. In it and in the factory clinic, people asked questions, sought for guidance. We managed to do the test. Even in our clinic, we do the PCR. And the medical area monitors people, if they had it, with who they maintain contact, where did they go. If someone has been identified as positive, they have a whole hygiene protocol. In the producive areas, in addition to masks, face shield, there is a whole protocol of for cleaning work tools. The operators participated with us, providing all the subsidies we asked for, including helping us with the communications we made to employees and family members. Operators also helped us with daily reports of suspected and contamination of our population. So you can see in blue some things that were important in their interviews that we are going to talk about more after in the discussion, but to amplify the importance of the communication of the operators and the daily reports, to call the company's clinic, the Help COVID, and all these strategies to keep people informed. So the study showed that large industries invested in communication with their workers in the integration of occupational health in healthcare in the use of teleassistive technologies to provide comprehensive healthcare for them. But in small companies, they have either not invested in communication actions or the topic, but have restricted themselves to replicate the communication materials produced by health operators for the employees and family members. And as I already started saying, the big industries, they immerse themselves into a strong communication work considered a fundamental front of the policy to fight the virus, to fight the pandemic, and to fight fake news, to fight the fake news scenario, and also the lack of information about COVID. We all went through there in the beginning of the pandemic, don't know what to believe, don't know what's right, what's wrong. So that's why a communication who fights fake news and brings information to everyone was so important, as I pointed here in some of their words. So the communication tone they used was a positive textuality anchored in a dialogical and simple language posture, concerned with talking, clarifying doubts, and creating an environment of closeness, transparency, and trust. The communication was based on prevention and care content, using channels such as COVID Bulletin, Help COVID app, and corporate intranets and online lives. So another more of their sayings. We felt the need for close communication. It was necessary to demystify some things, calm people down, and help with correct information. It was extremely important. So as I was saying here, the communication was based on prevention and care content. Então, the prevention and the care were the guidelines that guided the content. As they said, the idea of care permeates all of our communication initiatives, and there was a lot of communication and a lot of focus on preventive communication. And to finish the presentation, we brought some conclusions about the interviews and the results. We noticed a cultural rupture process in work. So home office was already carried out by some companies, but the practice was surrounded by suspicions and doubts, and now is being studied to be implemented more times. And there were no unavoidable complaints about the home office, only the recognition of the need for adjustment. So it's definitely embraced as a productive and viable work dynamic. And there were high rates of approval of the practice of homework by managers and by employees, and also brought a corporate discussion to improve the method about whether to assume the administrative costs of those who work from home, like Wi-Fi, the ones who needs a computer, maybe a chair, the administrative costs from working from home. And also from the results of the interviews, it was shown that the confrontation of COVID was different between small and large industries, mostly because of the infrastructure, the difference between infrastructure of the companies. So large industries had more to offer, and some measures adopted may break with the traditional process of healthcare at work, with the inclusion of comprehensive health days and preventive measures to management of people with diseases, mediated by the articulation between occupational and assistance health, and the use of technologies to amplify communication, bring correct information to their workers, and also spread preventive and coping measures to the workers, to them. And that's it. This is the end of the presentation. I am Ana Luisa, but these are the three the persons who helped me, who helped with the presentation and the work. So Ana Carolina Cisnando, who also is a medicine student, Jorge Antoni, who works in SESI, Serviço Social da Indústria, Edgar Vieira, who also works in Serviço Social da Indústria as a specialist. So that's it. Thank you very much. I appreciate your time and effort to be here. That's it. Good night.
Congratulations to Ana Luisa and the whole group for this work with such a relevant and current theme. And now moving on to the next one, we will have the oral presentations by Braulio Escobar. And the title is Correlation Between Depression and Hereditary Factors in Patients, seen from March to December 2018 at the Integrated Teaching Medical Outpatient Clinic of the University of Southern Santa Catarina.
Hello, my name is Braulio Sambaqui Escobar. I am a medicine student from Brazil, and today I will be presenting my study. The title is Correlation Between Depression and Hereditary Factors in Patients, same from March to December 2018 at the Integrated Teaching Medical Outpatient Clinic of the University of Southern Santa Catarina. Now I will start with a little bit of history, a brief history of the depression. Hippocrates coined the name melancholy from two other words, melas, meaning black, and chole, meaning bile. Melancholia, therefore, means black bile, one of the four humors that make up the human body. This is one of the first mentioned to the mental diseases. It was in the Enlightenment that the Dr. William Cullen used the term neurosis for the first time and classified melancholia as an alteration of nervous function and not as one's thought of moods. In the 19th century, the first time the term depression appears as a sense closer to the correct one, while the term melancholy could be associated with any type of madness. In the 1980s, the first studies relating depression and genetics began to appear. Associations between mood disorders and genetic markers have been reported for chromosomes 5, 11, 18, and X, characterizing the relationship between depression and genetics. The higher prevalence in women shows that depression has associated environmental causes, multifactorial inheritance. This is really important because even though the person may have the genetic for the disease, the environment will play a really important role in developing or not the disease, because the situations that the person is exposed will be very important. He can develop the disease without the genetic for it, and he can have the genetic for the disease and don't develop it if he is exposed to the right environment. The American Psychiatric Association, through the Manual of Statistics and Diagnosis of Mental Disorders, DSM-5, affirms that the first degree biological relative relatives of individuals with major depressive disorders have a 2 to 4 times greater risk of developing the pathology, being heredity of approximately 40%. Depression is considered a serious public health problem due to its high prevalence, affecting over 264 million people worldwide. In the objective, we have the main objective of this study to verify whatever there is a correlation between patients diagnosed with depression and genetic factors in an outpatient clinic in Salford, Santa Catarina. Specific objectives: perform a clinical statistic among the percentage of cases of depression in families, find out the age of the first episode of depression, to analyze the degree of kinship between patients with the syndrome of the same family, identify the social demographic and clinical profile of the participating patients, relate the patient's lifestyle with the occurrence of the disease. In the methods, this was a cross-sectional study. All patients were over 18 years old, diagnosed with depression, and who were seen at the Integrated Specialties Medical Clinic of the University of Santa Catarina were included. The questionnaire was structured by the authors and all the data extracted from the medical records. All the data was stored in Excel and later transferred to SPSS version 20.0 program for analysis. The numerical data were presented in mean and standard deviation, and the categorical data in absolute and partial frequencies. For the numerical variables, the ANOVA one-way test was used, and the categorical data chi-square test was used. The confidence interval was 95% with a 5% level of statistical significance. So here we have the results. 67 records were analyzed with a mean age of 48.24 years with a deviation of 13.28 years. The female sex represented 88.1% of the population. So we had 59 females and 8 males in this study. The marital status: 42 patients were married, which is more than half of the population. 15 were single, 5 widowed, and 5 divorced. In the education, we have 34% in complete elementary school and 19% with complete primary education. This is a big part of the population have low education, 6% in complete high school, 2% in literacy, 4% complete higher education, 2% incomplete higher education, and 18% complete high school. The average age of onset of the first depressive symptom was earlier in males. In addition, 53.7% of patients have or have had suicidal ideation, and of these, 31.3% have previously attempted suicide. Almost half of the study population had at least one relative with the same diagnosis. 49.3%, being primarily first-degree relatives, 40.4%. Here are some of the triggers for the first symptom: death of the family member or husband, almost 12%, marital problems, 28%, after disease diagnosis, 13%, change of routine, 7.5%, job, 7.5%, end of relationship, 3%, family or husband disease, 3%, and it was not in the medical record, 25%. So we can see there is really significant in family issues. Here we have that 33 patients had at least one relative in first, second, or third degree with depression, 49.3%. Of these, 16 had a mother with the same diagnosis, corresponding to 23.9%, being more prevalent in males. For participants, 50% against 12 of the opposite sex, with 20.3%. The P was 0.065, meaning 6.5%, not the 5% needed to have significancy in our test, but really close. The rest of the family relationships are described in the table. So here we have a column for male and a column for female and a column for the significance, statistical. First of all, males have 0 fathers with depression. The females have 5 patients had fathers with depression. In the males, we had 0 daughters with depression. In the females, we have 3 patients with daughters with depression. Males had 0 sons with depression. The females, 3 sons, 3 patients with 3 sons with depression. Here it's important. The males, 1 had a sister with depression, and the females, 12 had sisters with depression. The males, the brothers, 0 with depression. The females, 3 patients have brothers with depression. Males, 1 aunt with depression. Females, 3 aunts with depression. Uncles, 1 for the males and 4 for the females. In the conclusion, the majority of the patients are females, adults before the age of 50, married, with low level of education. And it's important to notice that we didn't have many daughters with depression, but many patients have sisters with depression. This is probably due to the first symptom came around 39 years old, and the patients have around 48 years. So probably the daughters were not in age to have the first symptom, and the sisters have a closer age to the patients. So there are more sisters with depression. The low level of education is due to be a free clinic associated with the university. So there are many patients with low budget, and that's related with the low level of education. Almost half of these patients have at least one relative with the same diagnosis, mainly first degree. Also, more than half had or still have suicidal ideation. Although the present study showed diagnosis of depression mainly related to the female sex, there was no statistical significance when comparing the relatives separately or grouped into sexes with the sexes of the patients. So as we discussed before, we almost reached significance, but it was not enough. We needed 5% and it ended up in 6.5%. But maybe this is due to our low number of patients. And it's important to discuss more of this area because this is a really important disease, the depression, with many people ill, and it's really important to prevent this disease, and knowing it's genetic, it will help many people. So it's necessary to conduct more studies about this topic with larger groups to maybe prevent the disease, to take its course in the patients, in the people, because this will be, it's already a great problem and will be even worse because the numbers shows that many people are becoming depressed around the world. So it's really important to make more studies in this topic. I would like to thank you all for watching my presentation. I am really glad that you came to the end. Here is some of my core references to this study. And here is some of my contact information. If you want to ask a question, or if you want to say something, if you want to continue this study with me, I would like so. This is my Instagram, my email, it's a Gmail account, and my WhatsApp with my Brazilian number. I will be glad to answer any question. And please feel free to contact me. Thank you all again, and bye.
Congratulations to the whole group for this excellent work. Depression is a very common disease nowadays and should always be discussed and studied. And now we'll have our second break a little bit sooner than expected, but we will return in a couple minutes with lectures by Dr. Marina Celi, Blanca Castillo, and a pre-recorded interview with Dr. Claire Gerard. See you soon. Welcome back. Let's start our last round of presentations. Now we will have the lecture by Blanca Castillo. Blanca Castillo is a recent graduate in biomedical science, University of Barcelona, Spain. She developed her expertise in public health issues throughout her work within the IFMSA as the Public Health Regional Assistant for Europe. Today, she will talk about health systems awareness among students, a must in a globalized world. Please welcome Blanca.
Hello, everyone. I'm gonna share my screen so you can.
Not yet. Oh, yeah.
Prepared. Yeah.
Perfect.
You should be able to see it right now, right?
Yes.
I'm gonna. Okay, awesome. So thank you so much for having me. First of all, it's a great honor to be here and also to explain you one of my passions, which is health systems and also global health, of course. So as they already told you, I come from a background regarding biomedical sciences, but also public health, which is one of my passions. And I also wanted to share with you today the importance of getting to know how our health system works among students, of course, so we can know how actually to tackle the importance of health systems and also how to get improved in a national and local level. So yeah, just get it started. Okay, so I wanted to start by mentioning how global public health is included in the medical curricula, because the IFMSA, the International Federation of Medical Students Associations, which is a great federation, including quite a lot of countries, actually, I will say that it's 150 or around this. They launched an online survey from December until March in 2018, and they had 327 responses among 139 countries. And they asked to themselves how public health is assessed in the medical curriculum and how important this is in the medical schools. So they wanted to know the importance or like the opinion of students when it comes to learning more from public health in their medical curricula. And here you see some results. They actually have more that you will actually find in this student's toolkit. But I wanted to stress the importance of two concrete results. The first one is the one that you can see here in the left. They asked to the responders the importance or what range of public health knowledge they think that should be taught during medical schools. And you can see that the great majority actually said that it's important to have local community public health, but also national public health and global public health as content within the curricula. And then afterwards, they asked to themselves as well and to the responders whether they think that public health should be taught in an alone course or also as a degree program. And the 71%, so actually the great majority, also said that it's important to have in both stands in the both types or both options, so as an alone course, but also as a degree program. So I think that we could all see that the students value the content that they learn in regards to public or global public health. And then afterwards, we could ask to ourselves what happens with health systems, because they are actually a great topic within global public health. And health systems are often left behind. There's actually one study that assessed the framework that the different medical curricula have in regards to health systems, and they saw that there's actually no framework to include these in the curriculums. So of course we will actually need to work towards that in order to include this content in an inclusive and critical way, so that it's not marginalized emphasized in the medical schools, and that the students can get to know more about their own health systems, but actually the importance of getting to know other health systems. That's why the importance of a globalized world and getting to know the different types of systems that you can actually find in different countries. But as we said, there's no actual framework that could assess that. So I wanted to do a short analysis with you all when it comes to health systems and how these health systems can actually, or how students can identify these health systems within their own context. So if we're talking about health systems, we will actually talk about them or analyze them in a framework that the WHO developed some years ago, the WHO Building Blocks Framework. And here you can see the 6 building blocks that this framework identified. And health systems as a whole, we can actually define health systems as the conjunct or like the branch of institutions, organizations, and also people that work towards providing health to the general population. And that's why I also pointed out people in the center of this diagram, because people are sometimes the element that is left behind when it comes to health systems and when we talk about health systems. So yeah, I just wanted to point out that people is actually a crucial point within health systems and as a crucial element as well. But if we go step by step, so if we identify the different building blocks, as we said, we have 6. The first one is regarding service delivery, which comprises quality, access, safety, and coverage. But if we talk about service delivery and we think about our own context as students, you can even think about you being in a hospital during your internship or even other contexts that you have experienced as a healthcare student. You could actually think about what's the quality of the services that you have learned throughout the different years that you have studied in the medical curricula or in the medical school. But you could also think about who is covered in your country or in any country, because as we already said, we live in a globalized world. So I'm sure that apart from the health system that we will need to experience in our own country, we will also need to face other situations in other countries and other health systems. And finally, we could also ask to ourselves, what's the offered safety of the techniques that we are learning in the university? So actually, we could identify different things from this service delivery, which is one of the pillars of a health system. Then afterwards, we have health workforce. And actually health workforce, we are all health workforce because we will be the professionals of the future. But a well-performing workforce consists of human resources management, skills, and policies. And I highlight these skills and policies because they are the elements that we sometimes forget because we are not that used to work with them probably. But if you think about this, you can actually ask to yourself as well, is my university or is my school providing me with all the needed skills and knowledge for me to be a good professional in the future? So we could actually ask to ourselves whether we are learning enough in regards to public health, which is right now a great topic with COVID-19. But we could also ask this to ourselves when it comes to climate change, which is also a topic or a problem that we will all need to face in the future and right now, but it's not included enough or yet in the medical school, for instance. And finally, health systems, which is the topic that we are talking about today. Then afterwards, we could also ask to ourselves, how are the policies of my country when it comes to any kind of service that we are providing as a health system? And also another question that you could ask to ourselves in a more practical way. So for instance, the spots that your hospital has for healthcare workers, because if you are doing an internship in a concrete hospital, you will also need to work with other professionals that are already working in that hospital. And perhaps this is actually a very practical question that you could ask to yourself in order to know the number of spots that this hospital or the national health system offers to the professionals, and also the spots that you will actually need or have in the future as a professional as well. So this, when it comes to health workforce. Then afterwards, we have information. So a well-performing system ensures the production, analysis, dissemination, and use of timely and reliable information. Okay, we could all agree with that. But then this is also something that we could identify in our own studies. So for instance, all the techniques that or technologies that have been taught to ourselves or to us during the school are updated enough. We will know how this information will be provided to us in a practical manner, or is the knowledge that I'm learning outdated? Because this happens quite a lot, and right now with research that has a great potential to discover other ways of practicing the clinical medicine, it's actually a topic that we should ask ourselves whether we are updated when it comes to the information that we learn or not. Then afterwards, medicine and technologies, and this is actually a hot topic when it comes to, for instance, vaccines, when it comes to COVID-19, as we said, etc. But the supplyment or the supply programs actually that need to be equitable and need to be accessible and with a great quality and cost-effective use for people is actually something that we should all consider when it comes to including this service in our health system. And we can ask to ourselves, as I was saying during all this time, what technologies do I have in my hospital for clinical practice? Are these technologies, we could also relate this to the information, are all these technologies outdated or not? Will I need to learn more technologies during my career in order to be a good professional? Then afterwards, what national programs do I have in my country? And that's actually quite important also if you are traveling to other countries or if you're having internships in other countries, because perhaps these national programs change because they have other policies or other services to the general population of that concrete country. And these programs might differ from the ones that you have in your own country. Then another question, do other countries, as I was saying, have X vaccine in their national program? And this is, for instance, as I was saying, when we travel abroad, we all need to check whether we have these vaccines or we need to get those ones as well if we want to travel to that concrete country or another. And that's actually something that is controlled by the national health system and by the medicines and the technologies that have been offered in that concrete country. So if we are moving to another country, this is something that we also need to take into consideration. Then afterwards, financing. This is actually a pillar that perhaps as students, because perhaps it's a bit more complex and we're talking about money and funds, etc., etc. But for me or personally, I really think that this is a pillar that we should all need to learn, because we're talking about the money or how the national system covers all the expenses that we have as a nation, right? So what does my national system cover? How does the system get financed, and where does the money come from? Because like we're, for instance, I'm from Spain, so in my country we have universal health coverage. So right now, if you have any kind of emergency or any kind of need when it comes to, of course, like health, you can go to the hospital and get treated, and you won't need to pay for absolutely anything. But are we thinking about the costs and expenses of this service? Because we won't be paying for them, but someone needs to pay for them. And if it's not us, who will be paying for them? Of course, we are paying for them indirectly with taxes, etc., but it's not a direct cost that we need to pay for. But of course, there are different models. There are different health systems. And for instance, if I will live, or if you will live in a country that has an out-of-pocket model, then you will need to pay for any kind of service that you need once you go to the hospital. So every time that you go to the hospital for any kind of treatment, then you will need to pay for it. So as you can see here, this topic is quite complex and quite difficult to analyze, but at the same time, it's also basic knowledge or a basic understanding that we should all have when it comes to covering these expenses that we all generate in the national health system. And then last but not least, we have the leadership and governance pillar. And perhaps this is also something that we kind of idealize, or in my case, I really do it, because when we think about leadership and governance, we think about the Ministry of Health, the National Ministry of Health, which they are controlling absolutely everything, the programs that we have, the services that we offer, etc., etc. But we could also think about leadership and governance in our local level. So, for instance, the hospital that we are where we are having an internship, I'm sure that this hospital will actually have a medical director who will be managing absolutely everything, and this hospital will also have a board who is also making decisions when it comes to everything that absolutely every service that the hospital is providing to the people. So when it comes to leadership and governance, we could actually ask to ourselves, what's the decision-making body in charge of X, so any kind of health issue, but also what's the policy framework of X topic in my country. This could also be related as well with health workforce and the policies, the knowledge that we have in regards to policies. And then finally, who is in charge of controlling the functioning of the system? Perhaps in this case, the national level is more in charge of this, but we could also think about that in a local, in a local and community level. So yeah, these are actually some questions that I just did out of a brainstorming process, but you could ask these to ourselves and even more questions when it comes to every single pillar of the health systems. So you could actually identify that many of the different question points that you have in these pillars are also referring to you as a student. So it's actually something important to know and important to discover while you are in the medical school or university. And here I also left some benefits of knowing how health systems work as a student, because we kind of analyzed and summed up the different things that we could ask to ourselves when it comes to the different pillars of the health systems. But when it comes to the health systems as a whole, we are not talking about a national or international level, but the health systems as a whole in a theoretical level. Then we have some questions mark that we will also think about together. So for instance, the fact of getting to know how a health system works, or how, as I was saying, that theoretical level when it comes to health systems work. We have, for instance, exchanging views and ideas with colleagues. And that's actually something very fruitful, because you will be the future professionals, or we will be the future professionals in the future. So exchanging ideas and trying to improve the current system, if it can get improved, which I'm sure that it can, then it will be a great exercise for us to know what we can tackle, altogether in the future, as well as future professionals. Then afterwards, a globalized world. We all know that we live in a globalized world, and that's actually something that we should need to bear in mind. And we can see that with the example of the COVID-19, because the COVID-19 has affected every single country of the world, perhaps not every single, but I'm sure that the 99%. So this problem, this national problem that a concrete national health system need to tackle is also a problem that another national health system has also need to tackle in this manner. So it's not an individual, an independent fact. It's actually something that is acting globally, and that of course partnerships and other efforts that we will take together are of course beneficial for all of us, not nationally, but also internationally and globally. As I was saying as well, future professionals, we will be the future professionals of the future, of course. So this is something that we should also take into consideration also when it comes to exchanging ideas, views, opinions, because in the end, we will be, I'm sure that any student who is right now studying medicine or any kind of healthcare study will be, for instance, the Ministry of Health of, I don't know, any kind of country. So this is actually something that it's really important, because right now we are learning the knowledge that we will need to use in the future. Then policy implications for people. Of course, when we see in the television that the government has approved this and this law, we of course know that this will apply to us in some cases, but we should also take into consideration that any kind of policy has implications in our own lives, and also in our daily basis. Then last but not least, well, not last, but almost, the general culture. Perhaps it's because I really love health systems, as you can see, but to know the background of health systems, or to know the background theoretically, as I was saying, of how health systems work, is actually everyone's responsibility, because we are all living together in a nation. So every kind of person has a different role in the society, and everyone should actually know what's their responsibility, apart from being or not in the health workforce or not. So as I was saying. And then finally, youth as change makers. I really think that this is an important fact. And there are actually many studies who have showed that youth participation fosters a deeper sense of empowerment and leadership potential. And this is actually something that we need to use in the future, as I was saying, also connected with the fact that we will be the future professionals of any concrete country. And finally, I would like to show to you a concrete example of what happened in Spain, which is my country. I concretely live in Barcelona, but yeah, like as a nation, Spain. Here you can see, it's in Spanish, of course, but here you can see a screenshot of a concrete law, royal decree law that was approved 8 years ago. And I am explaining this concrete case because it was really, really, really important in that moment, and it's actually really important right now. And also as healthcare student, it's something that really impacted our context. So before this 2012, we had UHC in Spain, universal health coverage, and everyone could get treated if they needed to go to the hospital, etc., etc. But then in the 2012, a royal decree law was approved, and thanks God, after I will say 3 or 4 years, this royal decree law was got declined, and then we return once again to UHC. But why I'm explaining this to you? Why is important? So the Spanish national, just for you as a background, the Spanish national health system offers free access to a comprehensive package of services and benefits covering primary health care, specialized care, and also emergency care. So this national health system is funded almost entirely with taxes. And since 2002, the system was decentralized. So in Spain, we have 17 regions, and every region could actually manage the provision of healthcare in their territories, and in designing and implementing legislation binding in their respective regions. Among other functions, the national government is in charge of designing and implementing national legislation applying to all regions, and of undertaking the general coordination of the system, okay? But just for you to understand the why I'm explaining this to you, all individuals in a UHC condition, all individuals living in Spain were entitled by law to receiving free access to the system, irrespectively, so no matter what's the personal wealth, labor status, or administrative situation in the country. In particular, undocumented immigrants were entitled to the same bundle of services as Spanish natives, with the only requirement of being registered as residents in a municipality, which is a very simple administrative procedure. The thing is that in 2012, so when this royal decree law was approved, with the official aim of saving resources and dissuading the health tourism, which was a very big problem here in Spain, the Spanish government implemented a reform, the reform that I was talking about, of the health systems with the approval of that royal decree law that I was explaining. The new law, which came into effect in September, if I'm not wrong, of 2012, restricted free access to the healthcare services for the population of undocumented immigrants, changing the universal nature of the system, of course. In particular, the reform established that the point onwards, so from that concrete month onwards, immigrants needed an official residency, so like all the simple procedure that I was explaining to you that was required. They needed an official residence permit in Spain in order to be granted of access to the system, which is right now a very long and sometimes unsuccessful process. So this meant the approval of this royal decree law meant that undocumented immigrants were restricted access to all the services offered by the national health system, with 3 exemptions. So the emergency care in the case of serious illness or accident, whichever the cause, until discharge. The second one was healthcare during pregnancy, birth, and postpartum. And the third exemption was healthcare for individuals under 18 years old. But how this applies to what I'm explaining to you. As you can see, the royal decree law had a big impact in undocumented immigrants, which are, I will say that, quite a lot here in Spain. And here you can see 2 studies that were performed after the royal decree law was approved. And these 2 studies showed that during the 3 years of implementation, the restriction increased the mortality rate of undocumented immigrants by 16%. So actually the change of the health system in our country provoked the increase of 16% of mortality among these undocumented immigrants. And actually this mortality could have been prevented by rapid and accessible care to these people. So these results actually showed that the health status of vulnerable populations were actually under risk because of the fact of having changed the health system. So what's the problem behind this? Why I'm explaining this to you? Because as you can see, of course, this change was, or the national health system change was changed 3 years ago, three years after the approval. But why is this a problem? The thing is that people don't know their rights in the national level, and also healthcare professionals don't know what to do when it comes to visiting or having an appointment with undocumented people right now. And the problem comes with the fact of lack of information when it comes to how the national system is working. Because I can actually explain you a personal experience of one of my friends who was visiting the hospital, because she's actually a medical student, and she was in the hospital, and one undocumented person came to the hospital because of an emergency, and this person could not be treated, and this person was not treated because of the fact that healthcare professionals didn't know that they could actually help these people, and that these people had the right to be helped and had the right to have access to healthcare. And that's the problem. The problem is that people, both the healthcare professionals, but also the students in that case, didn't know how the health system worked in that concrete point, because it was right after the decline of this national health system decreed law. So here's where the problem comes from. What's the right of the people who should have access to healthcare, right? So yeah, I just wanted to leave this part of the, well, not part, but this presentation with this thought, with this take-home message, because of course the fact of sharing what's the right of people when it comes to healthcare access should be promoted nationally, but we can afford unnecessary and preventable diseases just because people didn't know that they could go to the hospital. So as a students, we should actually promote this as well, and promote the fact of getting to know a bit more about health systems and how the health systems of our country work, and also internationally. So we could also help people in a community level, but also in the international one. So yeah, that's mainly it from my side. I don't know if I'm running out of time or not, but yeah, I will be glad to answer to your questions if you have any. And then, yeah, that's it. Thank you so much.
Thank you so much, Blanca. The question is a little bit late. We'll have the lecture by Dr. Marina Souza first, and then we'll have a discussion table, okay?
Super.
Now let me introduce you to Dr. Marina Celi. She started her career as a community health nurse in 2005 in Brazil. She is a master and a PhD in nursing, and also has a graduate certificate in public health and gerontology. She is currently an associate professor at the Department of Public Health at the College of New Jersey. She works as a hospice nurse for Penn Medicine Principal Hospital in New Jersey, USA. Today, she will talk about successful global initiatives in aging. Welcome.
Thank you. Good afternoon, everyone, and thanks very much for this opportunity. I'm very honored to contribute to this discussion, and I think you have already introduced me very well. So I'm Dr. Marina Souza. I'm Brazilian, but I work at the United States. I've been working as a professor, as both a professor and a hospice nurse for 4 years now, almost 4 years now. So it's really a pleasure to be part of this event, especially because UniBH and all the background, the people that are working and idealizing this event, it's from a very special university and institution for me. So thank you very much. I'm gonna start sharing my screen with you. And I wanted to talk today about a few successful initiatives or experiences in aging globally. And I picked this topic especially because when we talk about aging, we tend to see so many downsides of the aging process. So we usually talk about diseases, we talk about how people disabilities, diseases, and problems in general. And I really wanted to bring a discussion on how to prevent diseases, how to promote health, and how to have a healthy aging. So there are so many discussions out there about the global challenges of aging and how to age healthy. So I think that's the main goal for all of the healthcare professionals, right? We not only as healthcare professionals, we want to provide the best care possible, but if we as human beings, we also want to age healthy, right? So we also want to get there, and when we get there, we want to be able to perform the activities of daily life. We want to be able to walk and talk and make our own decisions, have autonomy. So there are many discussions out there on the challenges of global aging. And we all know that we have so many, we've been witnessing overall so many changes in the world that has contributed to the aging process. I think we can't talk about healthy aging without understanding a little bit of how the reasons why the world has been aging and processes. So overall, we all know that the percentage of older adults have increased overall due to mortality, fertility, and migration. So those are probably the three main reasons why countries and populations have aged. And I wanted just to highlight something here. As you can see here, we have in 1992, the world's 20 oldest countries. So as you can see, when we analyze the percentage of population 65 years and over, and if you take a quick look on the countries on your left, you're gonna see that we have basically high resource, well-developed countries, right? Especially in Europe. Most of the countries here, they are located in Europe or Southeast Asia. So we see that back in 1992, about 20 years ago, most of the countries where we see like a big older adult population, they were well-developed countries. And I wanted to contrast this data with this other information here. So this is the increase in older adults population or elderly population. So as you can see, look at the top 10 countries that have had their population increasing over time, and the projections for 2025. So we can easily locate many low and middle resource countries. So the message that I wanna deliver here is that the world has aged, regardless of the level of development, regardless of how much developed or economically or socially developed a country is, the world has aged. And that's something that we have to celebrate for sure, right? So life expectancy has increased. There is no discussion about this. We've seen like many countries increasing the percentage of their population in 200%, 300%. So that's something that we definitely we have a few hypotheses to explain this phenomenon, and I just wanted to bring some of them, like money and education. So once we have increased our income, the country's GDP, level of education, basically most of the social determinants of health that you're probably very familiar with. So all the classic public health measures like washing hands, access to healthcare, hygiene and sanitation, all the medical technology, right? Not only the medications, but the techniques that have been developed over time for surgeries, for treating chronic diseases or even infectious diseases, vaccination, changing lifestyle. So the way we, what we eat, how healthy we eat, the consumption of alcohol, smoking and exercising, they are all together, we can definitely help explaining this process of global aging. Social support is another fact that we have to take into consideration, because populations, of course, as we age, the demand for care and social demand tends to increase. So the more we age, the more help we need, the more we have to access our social support network. So there are many other reasons. We could stay here for hours and hours just discussing reasons that have contributed to this phenomenon that we are calling global aging. But I wanted to bring up a question here for you and for all of us to think about. So are today's older adults healthier than yesterday's? We've been witnessing, and it goes really along with the previous lecture when we talked about, when you mentioned the gap, right? The social and the health gap between immigrants in this case, and we can talk about older adults in the same way. So overall, we've been witnessing an important increase in life expectancy, but on the other hand, what about the quality of life? So does it matter reaching your 78, 80 years old, or does it matter how you are going to be when you get there? So that's the main discussion here when we talk about healthier or healthy aging. It's not only your age, but also the quality of life, how independent, how autonomous you are going to be to make your own decisions, to fold your laundry, to take your shower, to do the basic activities that you are expected to do. And there are many studies, many great experiences out there. I just brought a few papers here, recently published papers here, just to illustrate some of the interventions. And I just decided to pick two because I know that we have a time limit here, but there are many great experiences out there. So I just wanted to mention this first study that I brought here on Thailand. It's a case study where they actually were able to follow up in a community and get to know what have ways of healthy aging. So what do they do, and the way that they live, what they eat, how they the relationship that they establish as a community, the social cohesion matters in this case. So there are many studies out there. And the first one that I wanted to highlight here, and it's something that I've been involved with as a researcher, we have a research group that we have a few researchers from different countries like the United States, Portugal, Brazil, and we've been studying, I don't know if you guys are familiar with the age-friendly ecosystem or the age-friendly hospitals, age-friendly health system. So in Brazil especially, we have a very well-established policy on the hospitals, children's friendly. So where when a woman gives birth, for example, they have all the policies for breastfeeding, for stimulating breastfeeding, and all the other things that we can do to make sure that that baby is receiving the best care possible. And there is a very important policy that has been already implemented in many, many countries, especially in the United States and a few other countries in Europe, that it's the framework for age-friendly for an age-friendly system. So that it basically says that we have to create conditions for older adults to be able to be independent. So the infrastructure, the physical infrastructure, the way that healthcare professionals, they behave, and the policies and small interventions that we can implement in different places, they can make a huge, huge difference for older adults to live independently and increase their quality of life. So just a few examples of great studies that are currently happening worldwide. So why not have an age-friendly slums? So we have nowadays in many countries, this is in a country in Africa, but in South America, we have so many slums, so many favelas, right? And we have so many older adults living there. And we know that sometimes the geographical organization or the physical organization, they're not age-friendly. So it's almost impossible, not only for older adults, but for people in general with disabilities, for example. It's difficult for them to move from one place to the other. If they have to go to a doctor's appointment, for example, it's almost impossible. And then they get stuck at home, and that will contribute ultimately to depression, to loss of so many great things that they would be able to do if they had the structure and the conditions. We also have many, many studies supporting aging well on research, and we have policies and studies that have been already implemented in many countries, creating what we call age-friendly hospitals and health services. So all the healthcare network would be prepared to receive and to create conditions to serve or provide the best health care service possible to those older adults. So I'm saying that the hospitals will be prepared, the healthcare, the primary healthcare clinics. We have great examples, especially in Canada and in the Scandinavian countries, where we have age-friendly cities, right? Where you can find a great sidewalk that older adults can walk safely with a really low risk of falling, for example. So all those policies and all this, this initiative, the age-friendly ecosystem, it's already a reality, and it's being implemented, as I told you, in many places. And again, I just wanted to highlight that it's not only about the infrastructure, the physical infrastructure, but it has a lot to do with empathy, with understanding the older adults' needs, not treating them as children, being able to really understand their needs, having a healthcare personnel that it's really prepared to understand all the variations and all the needs of older adults in general. The second topic that I plan to talk to you and to discuss to you, it's about institutionalization. So we know that the families, they've been shrinking, right? Every new generation, we have less and less kids. So the families, they are getting smaller and smaller as the time goes by. And institutionalization, it's something that it's in a few cultures, I would say, especially in South America, institutionalization, or taking your parent to a long-term care facility, right? The nursing homes, or different names that we can call asilos or whatever, can be understood as something bad, like, oh, my kids took me to this institution, they don't love me, or they don't want me close to them. But we see that we definitely need to re-signify the long-term care facilities, something that it's very, very important to us if we really want to change this culture. I'm going to give a personal example. I have 2 kids. I have no expectations at all that my kids are going to be able to take care of me. And in the North America, and also in the European culture, it's very, very common that we plan where we are going to go, where we want to go. People tend to choose the institution, the long-term care facility that they are going to live. And this is just something absolutely normal, because overall, the older adults, they don't want to be a burden for their kids. So it's something that it's just accepted socially. On the other hand, in Brazil, I can give the example of Brazil because I lived in Brazil for over 3 decades. But in South America in general, it's not the way it actually is. Because especially the long-term care facilities, they are known as bad places where you are going to get depressed, your kids are going to dump you there, and they will never show up again. Usually the infrastructure, it's terrible because people can't pay for a private long-term care facility. So they are going to end up going to philanthropic long-term care facilities, which actually lacks the philanthropic long-term care facilities. They usually lack infrastructure, enough healthcare personnel, home health aides, nurses, physicians, physical therapies, and so on. So we definitely need to change this approach in many, many countries. And the example that I bought here, and I know that we won't have time, but the YouTube video that I have the link here, and I can send it to you. But if you Google the dementia village, a small village in a small town in Netherlands, which is a great example. And there are many others. I just picked this one. It's a 20-minute video. You can enjoy later and watch the video if you want. But this is just a great example of how we can make institutionalization humanized, empathetic, and a high quality in regards to healthcare services. So in this small village, especially, all the residents, they have dementia, severe dementia. The vast majority has Alzheimer's disease, and they are encouraged to perform all the possible activities of daily living that they can. So they have their small supermarkets. They have a small pharmacy that it's actually fake, because people who sell the goods there, they are employees. So they kind of create small things to really mimic the real life and to keep those older adults engaged, learning something new. And that is extremely important to combat or to push back the evolution of the disease, the progress of the disease. So I believe that, and this is a topic that I've been studying for a long time now, and I definitely think that we need more investments in when we think about institutionalization in general. So what is it to be done? So that's the question that we have. I don't have the answers, but I believe that we all together, we can, as healthcare professionals, as social professionals, we can definitely work and think about possible solutions. Again, we don't have to invent the wheel, right? There are so many great experiences out there. We definitely have to adapt and bring to the reality of our target audience and propose solutions for problems that we have. It's challenging. We don't have, again, all the answers. We are building the solutions together. But I believe that we have to be inspired by those great successful experiences worldwide. Thank you. This is my email. So if you would like to ask any questions, any further questions, feel free to reach me out at any time. I'd be very glad to assist you.
Thank you so much, Dr. Marina. Now I invite you, Dr. Carolina and Blanca, to our discussion table with some questions we selected. Wait a minute. The first one is to Blanca. You mentioned that a well-performer task force requires several skills based on a student's perspective. What are the top non-technical skills a health student should develop and improve?
Okay, that's actually a very theoretical question. But of course, I will answer under my point of view, or under what I think that we should all consider as part of the health workforce. But I also think that it really depends on the task that you have within this health workforce. For instance, I personally studied biomedical sciences. So for instance, you could think that I will be in the research part, which I am, but not in that molecular level. Right now, I'm working in the public health sector. So it will be more about knowing what's the need of the community and your society when it comes to the different public health issues that the society is facing. But if you're also in charge of, for instance, Marina as a nurse, she will also answer in another point of view, also taking into consideration the personal and the individual connection with the patient. if you will be talking about this with a medical or a doctor, they will also think about this in a more clinical way, and perhaps as a nurse as well. So I really think that it really depends on the role that you have in the health workforce as a whole. But of course, I really think that a skill that is required to absolutely everyone who is in charge of people, because in the end, health workforce, everyone who has a role in this health workforce, I really think that we are working for people in a way that we dedicate ourselves, or we dedicate our professional career to helping people, and also to providing healthcare to everyone. Or I really think that that's the mission or the vision that we should all have. So perhaps a skill that we should all need to have, of course, compassion, etc., but also determination and responsibility for all the work that we are doing. And as I was saying, no matter we're talking about the research part, the clinical part, etc., but we should. I really think that we should not forget what's the overall perspective of working and being a member of the health workforce. So yeah, like I didn't answer in that theoretical way, because I really think that if you could consult a book, you should actually have a list of all the skills that you could have. But yeah, it really depends, of course, on the role. But I think that as a part of a health workforce, there are some basic skills or some basic notions that we should all have, of course. So yeah, I don't know if I answered your question, or like whoever asked this, but yeah.
Yes, thank you. The next one is, how did the Spanish people see this change covering foreigners in the country's final cost? Was there any resistance against this change?
There were quite a lot of organizations and civil society who actually thought that this was not a good movement from the government. Perhaps we should actually talk about politics when it comes to this, because it really depends whether it's a right-wing party or a left-wing party. And actually, the government who applied this royal decree law was from a party who was not, or this party was not the same one as the next government. So the next government actually changed the entire royal decree law in order to change this status. But of course, there were a lot of people who actually didn't agree with that. And from a student view, we actually had a big movement as well, because of course we were leaving behind a lot of people who needed healthcare and needed to have access to healthcare. And just because of that, because of the excuse of needing more resources and needing more money, because in that moment in 2012 we were in a big crisis, in a big not political, but like the big crisis that I think that quite a lot of countries suffered from. And the government just said, like, yeah, we are in a crisis, so we actually need to have more money. And if we are restricting this, it's because of this reason. And actually, the studies that I showed to you, those two studies which investigated the consequences of this change in the national system, proved that they did not raise more money because of this change. What they just did is to increase the percentage of mortality of these undocumented people who actually needed to have the right of health as absolutely everyone, but this change in the national system didn't allow them to do so. So yeah, like as you can see, there was a big consequence in a national level, and a lot of people actually didn't agree with that. And thanks God, it got changed 3 years after the approval of this. So yeah, but I think that it's an interesting fact of knowing how health systems work. So yeah.
Thank you so much.
We can't hear you.
Dr. Carolina, wait a minute. Oh, I think it's fixed.
You muted. She's muted.
Oh, she's muted. I thought it was her speaking, not you. You're still muted. Do you want me to ask the questions?
Let's see now.
Oh, yes.
I was saying that greeting my colleagues here for this panel, Dr. Blanca and Dr. Marina, for being with us and for sharing their knowledge. The next questions that we have is for Dr. Marina. We got some interesting questions. So I'm going to start by this one. Do you think that these new beauty procedures allowing people to look younger than they are can affect how the world accepts aging? So that's your first question for you.
I'm not an expert in this representation of this change. I would say this superficial change, but I think so. We tend to deny the aging process, right? All of us, nobody wants to get old. That's the reality. That's what the social media shows. That's what we've been fighting against this process. Nobody actually thinks or accepts that we are going to get old. And once we get there, people want to look younger and not really being able to take a shower, to move from or transfer from the bed to the recliner. Nobody thinks that, well, I want to be able to, I don't know, we use the bathroom independently. So I want to be able to manage my money to buy whatever I want to buy. So I think that we've been living in a society where we take it for granted, right? We are concerned about our appearance, but we don't actually look in depth into other very important things. And of course that, and it will vary according to the societies. Like if we look at the Western, I would say the Oriental society, and we can take Japan as an example. They are extremely respectful to the older adults. Getting old means getting wiser, right? So everybody, once you get old, you are considered the most important person of that family. Like everyone will really respect and recognize the grandparent, for example, as the most important or the wiser person of that family. So it will vary, I believe, according to the society too. But there is, I think that there is a trend to really be more concerned with the physical appearance than actually other that I consider more important factors of aging.
Great, thank you. We have another question here for Dr. Marina. In the book, The Mortals, even in institutions well planned for elderly people, the authors state that the elderly felt depressed when leaving home. What would be the strategy to make this process lighter and easier for the elderly, for the older adults leaving their homes to go to a long-term care facility or a nursing home?
Well, we know that not only depression, but we have many other conditions that incidence is way higher in between or among institutionalized older adults when compared to older adults living in the community, right? So not only depression, but when we look at falls, for example, we have a huge difference in falls when we compare older adults living in the community and those compared to those living in institutions, in long-term care facilities. And the same appears to, it's the same pattern for depression. We have about 3 times more, at least 3 times more. Of course, it depends on countries, it depends on, we have a huge difference between when we compare private and public / philanthropic institutions. But I think that the number one reason is the social and family support. Many qualitative studies, when we get to talk to those older adults and get to learn from them what exactly bothers you, because okay, we have this huge incidence of depression, right? Okay, but what actually is causing the depression? So the main 3 reasons I would say is for it wasn't planned. So my child just brought me there. Nobody talked to me. I was brought there in the very last minute. I was informed that I was going to stay here for a week or 2, and it's been 3 years, and it's been 10 years. So this lack of planning and acceptance, I think this is one of the reasons. And the second reason that actually happens a lot, especially with single older adults. So for my personal experience, when we have many older adults that was never married, so their social support and their family support is very restricted. So sometimes they had siblings, but they all died. So they don't have kids, they have a very far niece. And we know how difficult it is, especially depending on the disease that this older adult developed. It's difficult sometimes to take care, even taking care of your parents. Imagine a very far auntie or a very far uncle that you don't have that strong bond. So family support is definitely one of the great reasons that we can decrease depression among institutionalized older adults. So we have to create ways to get the family engaged. We have, especially in philanthropic and public long-term care facilities in many countries, there are so many rules for visits, for example, right? I have a personal experience preceptoring students in a few long-term care facilities in Belo Horizonte, where visits were allowed Monday and Wednesday from 2 to 5. Most of people, they work at this time. So we have to create more flexible schedule for people to be visited, because sometimes it's not that, oh, the family just abandoned, but there are so many barriers for families to really get to see their loved ones. So I think that there are few things that we can do, doable things, easy things that we can do to make this approach easier. So improving, I think they're working on planning and being very transparent and empathetic and getting to talk to the older adult before just leaving them there, dumping them there and disappearing, and creating ways to strengthen the bond between the older adult and the family by removing the barriers.
Thank you very much. Leticia, do we have any other question for our speakers?
That's it for today. Thank you so much, Blanca and Dr. Marina. We had a very enriching discussion. And now we are finishing with our last lecture, that is a pre-recorded interview with Dr. Claire Gerada. Thank you so much.
Thank you. Thank you, Blanca. Thank you, Marina.
Thank you as well for inviting us.
Thank you, and congratulations on this event.
my name is Marconi. I'm professor at Centro Universitário de Belo Horizonte. Luisa is medical student of the last year at Centro Universitário de Belo Horizonte in Brazil. Paulo is master degree student and medical student at University of Porto. And we are very happy because we are fans number one of the work of Clary Gerada. Clary Gerada is a source of inspiration for us, and it's very good to have you here. We are very happy, and we are going to have the opportunity to interview this brilliant doctor from the United Kingdom, and it's a very, very nice opportunity. Thank you very much, Dr. Clary Gerada, to be part of our meeting. It's an honor for us.
And it's an honor for me as well. And thank you very much for inviting me. I only wish I could see you face to face, but sadly, we can't meet.
Now I'm going to invite Luisa and Paulo to start this interview. We prepared some questions about healthcare system because the NHS is a very important healthcare system. We learn a lot from your system, from NHS, and we would like to know some details about the system and the impact for the population. So we are going to start with Luisa.
Yes. Hi, Claire. First of all, I would like to say that it's an honor to be able to speak with you because you are so inspiration for everyone who wants to build a quality healthy system. So let's start with the questions, right? Nowadays, we see that the hospital-centered medicine focus on the use of complementary exams and new technology has been the focus of investment in some countries. However, in our view, preventive medicine plays a crucial role in health systems. We would like to know what is the importance of primary health care in the NHS.
Thank you very much, Luisa, and it's a pleasure to speak to you. Well, I just want to put things in context. I have worked in the NHS for about 40 years. So the NHS has been around for nearly 80 years. So I've been there, not quite from the start, but certainly for a good part of my life. Now, what makes the NHS different, really different, is that it is built on a bedrock, a foundation of primary health care, as well as being a universal system, free at the point of use. But its real genius, if you like, is that it's built on this foundation of primary health care. So I, as with thousands and thousands of my colleagues, we have what's called a registered list. So we have a list of patients who stay with us till they move. So from cradle to grave. So if they move and go to somewhere else. But if they stay in the area, I can look after someone from birth to death. And I've been a GP in the same place now for 30 years. So I'm looking after their grandchildren, not just the people that I looked after, but their grandchildren. Now, what primary healthcare does, it provides easily accessible care to everybody. You can be rich or poor, but you can walk through the door. Some people walk through the door 30 times a year. Some people might walk through the door once every 3 years. And it's not on how much money you can afford, but it's based on your need. So we are there being able to pick up the vast majority of our population, and about 90% consult every year, and over a 3-year period, 100% of our patients, give or take a few, will consult with us. So we don't just deal with what the patient brings through the door, their coughs and their colds, but we also do prevention. We do primary prevention, so we do cervical smears, we do primary prevention in terms of immunization, but of course secondary and tertiary prevention as well. We're easily accessible. There's a saying in the UK, we should only be a wheelchair distance away, not a wheelchair, pushchair distance away, so children's pushchair. Now, of course, with COVID, it's all changing, but every single patient in this country will be registered with a GP and they'll know which practice they're registered with. So we're a very, very accessible service that holds and manages uncertainty. We don't deal with diagnosis and single illnesses. We deal with uncertainty and the whole range of the patient. So to my mind, what makes a health system good is having primary healthcare system. But Louisa, there isn't a health system in the world now that can afford to have healthcare unless it invests in primary healthcare. Because we're becoming much more chronic and complex, multiple morbidity, living longer, you have to have a generalist at the front door, and you have to have an easily accessible service at the front door, such as primary care.
So nice.
In Brazil, our health systems is also focused on the primary health care. We believe that with the family and community medicine, would be the key to understand what problems the population affects the population and what is social, economic, and cultural factors determines their health.
Absolutely. I mean, your health system is built very much on our health system, on bottom-up community involvement, understanding the problems that your local people, very local people, have to deal with. So I look out the window and I see my patients' homes. Now, many years ago, we had problems with rubbish, refuse. It was all over the place. Now, as a local person, somebody living in my community, I knew that my patient, just as I was, this wasn't a good, healthy thing to have. So I will work with my local authorities and the social services in order to address it. So you're absolutely right. I see my role not just as inside the consulting room, but outside with my community, with my fingers on the pulse of my community, which is what you've got in Brazil and also in Portugal.
That's true.
The second question. Sorry, Marcon, you can say.
As a GP, you have the opportunity to know not just the patient, but the environment where he lives, and you can act on prevention of diseases. It's very interesting. I think the best healthcare system is those who provides primary care for the population.
Well, it is providing, if you take the two extremes, take the American healthcare system and let's say Cuba. Now, notwithstanding how the American healthcare system is funded, which is appalling through the exorbitant costs, but they have no investment in primary healthcare. So what we know is that if you have no investment in primary healthcare, what happens is the patient has to go to the specialist or to the hospital to get basic healthcare. You can spread your money much better if you have a primary healthcare system. So Cuba, for example, has absolutely excellent public health indices. It has good indices in terms of childhood immunization, in terms of morbidity, in terms of even obesity. The problem of obesity isn't as great as is, say, in some other parts of the world. And yet it has far less income. It spends far less of its GDP on healthcare. So the more, and the studies were originally done actually in America, beautiful studies. The series is called Quarterly Milbank, through Barbara Starfield. And she found that the more GPs you have per head of population, the better your health outcomes, even health outcomes that are dictated by hospitals. So it stands to reason. Now, of course, you need both. You need specialist healthcare, but the specialist cannot do their work properly if you don't have GPs, because they behave like generalists. If they see gastritis, they'll do an endoscopy, whereas I know that most gastritis is self-limiting, can disappear with a few PPIs.
Here in Brazil, for example, we have a very big population, and we have some social and economic problems also. For this reason, I believe that a healthcare system who provides primary care of good quality will impact our lives in a very, how can I say, in a very big, it will be a very big impact. So I believe that we have to learn from you how to do a good program of health, of primary care.
On a population, you'll get better outcomes because you're spreading healthcare across a larger population. Now, if you take individual though, so because individually, if you have a lot of money, you can afford to go and get the best healthcare. Again, if you look at the United States has some of the best healthcare in the world, but only available to very, very, very few people. But your question is, how do you get a primary healthcare system? Well, I mean, it's difficult because you have to have a culture of it. Now, again, in Brazil, you have got a culture on it, but you have to get your governments to invest. There is no point saying, we want primary healthcare and then spend no money on it. And to a certain extent, that's been the problem of what we've seen in the NHS. More money has gone to building hospitals with big scanners or tertiary services for cancer treatment than, say, investing in general practice. But so it's a political decision, but it's also engaging with the population to say, if you don't have primary care, how do you know where to go? Even as a doctor, how do you know where to go? If you've got a headache, you might go to the neurologist, but your headache might be due to arthritis. You know, how do you go? Let alone if you've got a multiple morbidity problem. So it's important for folk like you, for people at the start of your careers who are very intelligent and involved in this, to get into senior roles in policy, senior roles in medical politics, and just keep driving it.
Very great. We see nowadays there is a tendency of part of some governments to privatize health systems. We want to know, in your opinion, what are the benefits of a country have a universal and public health system?
Thank you. I mean, the long and short of it is, any private healthcare system, its responsibility is to its shareholders. I think that's probably the same in Brazil and the same in Portugal. If you're a private company, your responsibility is to make money for shareholders, full stop. Whereas in an insurance health system, such as our system, your priority is to make your best value for money and to make sure that the patient gets care according to need and not according to want. So in a private healthcare system, the incentive is to sell healthcare to people. So, and I can easily do that as a doctor. I can spend 1 minute with somebody and persuade them they need to spend some money on getting their mole sorted or their pain sorted. Whereas in a publicly funded health system, there isn't that incentive. Your incentive is to actually to save money, not to spend money. The most important aspect, though, of a private versus public is ability to pay. Healthcare, as far as I'm concerned, is a human right. And if healthcare is rationed according to your ability to pay, so, then it's not a system that I would ever want to work in. And I talk about, I'm sure you have the same in Brazil, the EasyJet, bucket airline versus the big corporate airline. We don't want to leave people waiting on the tarmac, waiting to fill into their aeroplane. We want to be able to provide people according to need, not according to want. There's some noise on here. Is it me or is it the system? Sounds like an aeroplane. Can you hear it?
Yes, I can. Yes.
Is it my system or is it your system?
I think our system, but okay. I don't think we can fix it now.
No, that's fine. But as long as you heard what I was saying, so I was a bit distracted. I mean, a publicly funded healthcare system delivers healthcare dependent on need and not dependent on want. It's also got much less what we call transaction costs. So when the NHS was purely public, the cost of delivering it was about 5% of the total budget. If you have an entirely private health system, then it can rise up to 30 or 40%. And those costs are costs of billing, costs of advertising, costs of claims, cost of getting money back into the system. So Those aren't cost delivering healthcare. So there's lots of advantages of a publicly funded universal healthcare system, rather than, of course, the worst example in the world, which is the American healthcare system, where we know that 75% of all personal bankruptcies are due to people not being able to afford their co-payments, not that they're underinsured or they're uninsured, it's the co-payments they have to pay when they get ill on top of their insurance payments.
In this context, for example, I would like to know your opinion about your opinion. In your opinion, what can low-income countries learn from the NHS?
Oh, listen, I think low-income countries can learn to put well-trained, and I say well-trained, primary healthcare practitioners at the front door of the NHS. Now, those can either be primary care nurses, primary care doctors, primary care pharmacists, but put a well-trained primary care practitioner at the front door. The second is to invest in prevention, to invest in your communities, to invest in housing and education. And actually, there are lots of other things you can do as a low-income group, which is to restrict, to restrict the what is available, say through pharmacy, through prescribing, and also you might want to start to restrict what's available in terms of hospital costs. But on the whole, if you invest in primary care, get good, well-trained gatekeepers, then the rest of the system will sort itself out. There used to be a saying I was taught when I was a child, which is look after the pennies and the pounds will take care of themselves. So if you look after the amount of people that are needing expensive hospital care and prevent them getting that, either by improving their healthcare through prevention or by providing good out-of-hospital care, then you will save the millions and millions at the other end.
Dr. Gerarda, could you give some advice for young doctors who want to be a GP?
Oh, it's the best job in the world. Can I tell you something? My father was a GP. So he came to the UK in the 1960s and he inspired me to be a GP. He inspired me by taking me out on home visits. He taught me what, I didn't understand it as a child, but he taught me about social deprivation. He used to show me families where they had no inside lavatories, 12 people to a tiny flat, tiny home, dirty, children with no shoes. And he used to tell me that the best way of addressing these inequalities was by investment in general practice. Now, I can remember him saying this and thinking, but Dad, you're a doctor, you're not a social worker, but actually a good GP is everything. They look after the patient in the consulting room and the patient outside the consulting room. Now, I have been a GP now for 30 years. I did psychiatry first. It is the most wonderful job. You can change what you do every few years, so you don't have to be always doing the same job. So I have been a GP along this side, but at the same time to work on drugs and alcohol, mental health. I'm now working on gambling, policy and practice. So it is the most eclectic, flexible job you can ever do. I feel sorry for hospital doctors. I mean, unless you reach the very, very top of your profession in a hospital specialty, you're stuck all the time doing exactly what you started, you'll do to the day you finish. Whereas I do so many different things than I did 30 years ago. So I think the clever doctors go into general practice and the ones that can't cope with life go into hospital medicine. And you'll make the most impact as a good GP. Patients come up to me, even now, send me letters telling me how much I helped them, and I can't remember what I've done, but you have such an impact.
Thank you very much. Dr. Paulo, could you do your questions, please?
Yes, let me just say that was inspiring to me as a young medical student, and in the next few years I will choose my specialty, and that's so good to listen.
Paulo, you'll never be unhappy. You'll never be unhappy as a GP. But the one thing I would recommend is if you just do exactly the same thing all the time, then you will get burnt out. What you have to do is have to diversify, to do general practice as well as whatever you're interested in public health or teaching or training?
That's absolutely what I think.
All of them, Paulo, because you have you want to be a teacher and a GP and a researcher, maybe.
Paulo, I did. I'm a professor. I did academic papers. I did randomized control trials. I've been involved in research and development. I did that a few years ago, but I still get involved in research. I still write probably more academic papers than people who have got a full-time job in academia. So, I write a 3-weekly blog. I've just written a book. So you can do what you like as a GP, whereas in a hospital, unless you're right at the top and you can dictate your own terms, you're stuck.
I can see myself doing that during my career. And
Good.
Now that you have talked about that you publish a lot of articles, recently you have, and I will quote, my life as a doctor, like everyone's, has changed beyond belief, maybe forever. The negative changes include, especially, the loss of personal contact with peers and patients. I have concerns about the impact of COVID-19 on doctors' mental health, and predictions from previous epidemics and pandemics showed that it may be profound. You have written this recently in an article published by the BMJ. What will you change to put physicians' mental health as a priority?
A very good question. You see, before the pandemic, physicians' mental health across the world was pretty bad, even in Brazil and Portugal, maybe Portugal a little bit better, though some studies have shown not as good. Porto, I think you had a very good time. And it's the intensity of the workload. So it's the intensity. It's not just the long hours, it's what you have to do within those hours. It's the constant work. So I think every single country has to address it, because if you don't address the workforce, you won't have the workforce to look after patients. And it's not just about resilience building of the doctor, it's about changing the way we treat doctors, giving them rest, not having very long shifts, making sure you get rest and you get places to have hot food. But with COVID, what I worry about with COVID, if you think about you as medical students and doctors, the most precious and pleasurable part of being a doctor is patient contact, isn't it? It's physically being with patients. It's physically being able to engage with them, physically being able to even to touch them. And I worry that as we're losing that, because we're seeing patients increasingly remotely, then we're losing the essence of medicine. Now, hopefully this won't go on for too long, hopefully. But I do worry that medicine is a relational activity. It's done between people, between doctors and nurses, between doctors and patients. And though we can do it remotely as we're doing, I think we're going to miss that relational activity that comes with physically seeing, touching, feeling, smelling, sensing our patients.
Dr. Gerarda, I would like to ask you if the NHS, is it ready for the second wave of COVID-19? What do you think?
Very good question. I went to the Nightingale Hospital in London. Now, in 2 weeks, they built a 4,000 intensive care bedded hospital. Now, they never put all the beds in, but when I was there were still 500 intensive care beds. Now, the first wave of the pandemic was mainly in London and the Southeast, and we, even in London, didn't run out of intensive care beds, okay? So we certainly had masses of capacity before, and with the Nightingale beds opening in the north of England, we have masses of capacity in the north. But what we haven't got is the workforce, because in my own profession, for example, a third of our workforce are either sick, shielding, or isolating. Now, that must be the same everywhere. And the same with nurses, the same. So we might have the beds and we might have the equipment, but what we're lacking now is the workforce. Now, in the first wave, volunteers rapidly came forward, recently retired doctors, medical students. So I'm sure that will happen again. So your answer to the question is, yes, we are prepared. My worry is, as with everybody's worry, is that what we're not doing is seeing the routine care, the routine cancer patients, the the routine scheduled surgery, because if we're filling the hospitals with COVID patients, then there's no space for everybody else. And that's the worry. It's not whether we can cope with the pandemic. But saying that, we still, for every 16 patients, for every one patient with COVID last time, there were still 16 patients with non-COVID. So, you know, we still had lots of patients in. So I think we will cope. I think that the hardest thing, though, for every health system in the world, not just the NHS, is the exhaustion of the staff. Everybody's exhausted. We've worked so hard. Very few people have had a break over the summer. And we're entering now dark winter with flu. Not in the best position, but, you know, we'll cope. We have to cope. What else are we going to do? Can't let patients die. So, yes, we'll cope.
Yeah. Now that you talk about the exhaustion, and let me continue on this topic that you have worked a lot during your career. Do you think that health professionals have a special stigma on getting some mental help, getting to the doc, to other peer and talk about his mental health?
Yes, of course. And I write about this. I've spent the last 12 years looking after doctors with mental illness, and doctors are notoriously bad at seeking help. There's personal stigma, you know, I'm invincible, I'm never sick. There's professional stigma, you don't treat colleagues as well if you think they're sick, especially mentally unwell. And then there's institutional stigma. The system doesn't want an expensive doctor going off on sick leave. Patients don't like it if you're sick. I mean, they don't like it if you're chronically unwell. So all of that means that doctors are very reluctant to seek help. They'd rather suffer in silence, not rather because they don't want to suffer, but they will suffer in silence rather than seek help. I'm hoping the next generation of doctors, though, are better than my generation. So I talk about when I got run over on my way to evening surgery. So I just finished my morning surgery and I got run over on my way to evening surgery. Now, any sensible person would have gone to casualty, wouldn't they? They ran over my foot. But what did I do? I took my bike back to where I did my morning surgery. I wheeled it back. I then got a taxi to my evening surgery, did my evening surgery in a lot of pain with blood. Why? You know, why? Where was the stigma and the shame of actually saying, I can't carry on, I've got a broken foot? So hopefully the next generation of doctors will not do what I've done, but actually will accept some vulnerability, can accept that maybe sometimes they need help, not just for physical problems, but for mental health problems as well.
Yeah, we should pay attention to that problem. I mean, especially I think during the pandemic, during COVID-19, as you said, the health professionals, not only the doctors, the physicians, but also the nurses, in some countries, because they don't have they reached a plateau on the number of cases, they don't have time to take a break and to prepare to the next wave. And that could be really dangerous, don't you think?
It's our case in Brazil.
Say it again.
It's our case in Brazil. We are still in the plateau, and the second wave is coming, and we are exhausted.
You are exhausted in Brazil. I've been watching the cases in Brazil. I mean, sadly, you've not even had, we at least had a diminution in the summer when we could go out and, there wasn't COVID, but you've had it plateauing. And as you know, you're going up again. And you are exhausted, but believe it or not, you're human and you have human needs. You get tired. And when you're tired, it's not so much you make mistakes, because the mistakes happen further down track, but it's your own health that suffers, because the last thing that will go, the last thing is your patient care. You'll go on automatic pilot, but not you, but one's colleagues will become mentally unwell. Some of them sadly might even kill themselves. So I think it is very, very, very important that you get some rest. Now, it's a cliche, but somebody said this isn't a marathon, it's several marathons. And unless you're a top-class athlete, nobody can run back-to-back marathons without a break. So I think we have to learn. The next stage for all of us is having to learn to pass the baton, rest. I had 5 days off, 6 days since March. So 6 continuous days. But other than that, I've not had any time off other than the occasional day here and there. It's not, I can't do it. You know, I need as much rest as others, if not more, because I'm getting older. So my advice is we've got to work in teams, in pairs, in triplets, and just pass the baton and not think we're invincible.
Dr. Gerarda, I would like to ask you to let a message for young doctors, to let a message to young doctors all around the world who, because you have a brilliant career and you are a source of inspiration. So we would like to hear from you some advices about medical career, a message for young doctors. We are starting our careers and would like to hear from you about medicine, about medical career, some advice that you can give to us.
All right. One of the happiest moments in my life, was about 45 years ago when I rang my father from a public phone box and I said to him, "Hi Dad, it's Dr. Gerarda. Shall I wait for this noise?" I think you've got drilling, haven't you? It's gone. So when I rang my father and said, "Hello Dad, it's Dr. Gerarda here," and I was a 22-year-old, 23-year-old, it was one of the happiest moments of my life. Even now, you know, I've been married and 2 children in between and lots of accomplishments. Being a doctor is the most extraordinary job you can ever do. You are allowed to, patients talk to you and tell you things that they never tell anybody else, even their closest and dearest friends and relatives. They disclose to you, they talk to you, they share with you. And you, as a doctor, get into what we call the swampy lowlands. We get down there with them in places that haven't got a technical solution, haven't got a diagnosis. We get in there with their pain. It's an extraordinary job over a career, over a lifetime. It's hard work. There are times when you want to leave it and walk away and think, what on earth did I do this? But each day now, and I can honestly say this, each day now, I enjoy as much as I did yesterday and the day before. It's a well-paid, reasonably well-paid, it's exciting, it's never the same. And I am sort of envious of you starting your career because you have such enormous challenges to build on, such as genomics and personalized medicine and digital, and how exciting to be at the start of your career when you've got all of those opening up. So congratulations on being a doctor, congratulations on being a medical student, and just, it is wonderful over the course of your career. If things get bad along the way, seek help. It's inevitable. You can't work so close to suffering without sometimes it sticking to you, but it's fabulous, and good luck. And thank you very, very much.
Thank you so much. This is the first edition of our Congress. Next year, we are going to do another one, and we would like to invite you anticipated to be part of our discussion. We learned a lot from your articles, from your studies, and for us Brazilians, you are a source of inspiration, like I said, for the Portuguese students the same. So we are very happy. We would like to thank you so much to give some time to discuss with us.
Thank you very much, and good luck all of you. Take care. Bye.
Thank you so much, Dr. Gerarda.
Bye.
It was amazing.
Take care.
That's it for today. We have now closed our first day of the Congress. We thank all the speakers and everyone who is attending, and we will wait for you tomorrow. Goodbye.